Good morning, everyone, and thank you for joining us today. A short disclaimer: the information presented here is for the purpose of informing the board. The views expressed do not necessarily reflect the views of the board or any board member. Please note that this is the first session today and will end at 11:30 a.m. The second session will begin at 1:15 p.m., so please join us back here on the same webinar. We are recording today's session. You will be able to access it on our website, ssab.gov. Questions and comments are welcomed and encouraged and can be submitted via the Zoom Q&A function or emailed to us at events@ssab.gov. You can also tweet us using our handle, ssabgov. Feedback is also welcome and can be sent via email to events@ssab.gov. And with that, I will hand it over to our board chair, Bob Junda.
Hi, everyone, and welcome to our session this morning, State Agency's Role in Social Security Disability Determinations. As Omar said, I'm Bob Junda, Chair of the Board, and on behalf of the Board, I'd like to welcome you, Board members Kim Hildred, Jagadish Gokhale, and Nancy Altman. Welcome you. And today, I'm going to hand it over to Jen Rigger, our senior analyst, to moderate the event. Go ahead, Jen.
Thanks, Bob, and good morning, everyone. I'm pleased to introduce Art and Melissa Spencer, two former SSA executives. The Spencers have decades of experience in the state-federal disability partnership, and they both began their respective careers in the Virginia DDS. They both also eventually assumed leadership roles in SSA's disability policy shop. To learn more about their distinguished careers, please check out their bios on the board website. Today, the Spencers will outline some features of the administrative regulations governing the shared responsibilities of SSA and the DDS. They will discuss the positive aspects of those regs, as well as some of their more challenging elements. The regs under discussion are found at Subpart Q, 20 CFR Part 404. For those following along at home, we'll link to those regs in the chat. We're grateful to have the Spencers with us today to share their expertise, and we turn it over to them with our thanks.
Thank you, Jen. All right, so Jen provided all of the board members, all of you, with an overview of the Subpart Q regulations, and that really helped in terms of us having to explain less. And we can spend more of our time really talking about what we think are the more important concerns of the day. Our goal today, Art and I, is to give you a better understanding of why Subpart Q is so important, especially why they need to be updated and then kept current. And I can't emphasize that too much. The regulations, like all the regulations operating the disability program, need to be kept current. So the Social Security Act paints a broad brush portrait of what the program must and can do and must do to operate disability determinations. The regulations growing from the laws put flesh on the bones. They are not written in an operational level. That comes more in the everyday guidance that the DDSs get in the Program Operations Manual or the POMs. But the regulations do identify broadly the responsibilities for both SSA and the DDSs, as well as some of the functions that their parent agencies need to take part of. So Subpart Q is the guiding narrative that really provides the only framework for the DDS and the SSA relationship. One way to think about the program is to strip it down to the basics. What is our job? To make disability determinations that are four things. They're accurate, they're timely, they're cost effective, and they're productive. So what does that mean? For accuracy, there's a lot of different things that happen. There's the federal quality review. For timely decisions, there's different measures the agency has for all of those things. For cost effective, there's a lot of measures the states have and SSA has. Cost per case, what's your medical evidence of record or MR rate, what's your consultative exam rate, what's your average cost for your consultative examinations, things like that.
I think what we're going to emphasize here is we'll talk in just a few minutes about what's good and bad with our current regs. What we're trying to, our performance standards for our current regs, what we're saying now is we need to take the time to think about what numbers we should agree to look at. And that, when I say we, I mean SSA, I mean the state DDSs, I mean the advocacy community. I interrupted, sorry.
No, that's no problem. So simply reading subpart Q, it seems pretty straightforward, seems pretty normal, seems pretty workable. But as with most regulations, there's room for flexibility in how you operationalize any regulation. But leaving some things open to interpretation also comes with its own challenges.
But to go beyond the surface, there are certainly issues. A primary example is the reg, and this is at 404-1641, and I promise never to cite a reg again today. Standards of performance for both processing time and accuracy. We still effectively use the accuracy standards, but the timeliness standard has been out of date for at least 2 decades. Today, the requirement of a 60-day processing time or worse means substantial failure in the regs. I doubt seriously if any DDS has much better than 100-day processing time. While performance expectations are one example, the entirety of subpart Q reflects that they're out of sync with time and given our programmatic experiences.
So aside from minor changes, the administrative regulations in subpart Q really have not been updated since 1981. Let me say that again, 1981, that's 40 years. So they are not, it's not the only out-of-date regulation. For example, the vocational grids were promulgated in the 70s and pretty much are the same structure that they've always been. The agency has proven that it can, given the resources and the commitment of those around them, they can make significant regulatory changes. The listing of impairments is, I think, a prime example. The agency has completed an overhaul of all of the listings. They did a really great job with that. Brought it up to current medical environment. Okay, we have set the stage. Now, what we really want to do now is just walk through the 4 buckets that Jen gave you in the handout, which is, in addition to performance, includes personnel, medical evidence collection and cost, and workload management and reporting, which includes fiscal. We're not going to talk about every item in every section because we'd be here all day. But in general, each section lays out the agency's responsibilities as well as the state agency's responsibilities. Okay, personnel. In its basic form, the personnel section lays out that SSA provides training materials and sometimes training itself. It's a key point that we're going to talk about in a little bit. The state provides all the things you would normally expect. They provide organizational structure, facilities, qualified personnel, medical consultant services, and a quality assurance function. And all those things, many of those things are operationalized in the everyday guidance that the DDS is used to run the program. So things that, some things to highlight. For medical consultants, DDS medical consultants, some of them are state employees, some of them are contractors. And while the requirement is for the DDSs to recruit and pay consultants adequately, the regulation allows for flexibility if the DDSs are not able to sufficiently recruit. It allows them to request assistance from SSA, and in this case, SSA has federal medical consultants that now can assist with adjudicating claims. Why is this sometimes a challenge? Because now in each of the 10 disability quality branches, the the organization that's responsible for looking at end-of-line quality and accuracy when the DDS adjudicates a claim, the doctors in the disability quality review process, in some cases, now act as adjudicators. So this somehow muddies the functions somewhat. Hiring. So the states are required to adhere to all state applicable rules for personnel. They're required to make personnel available to travel to meetings as may be sponsored or approved by SSA. And I lifted that language directly from the regulation. Subject to funding, the state will, best of its ability, facilitate the processing of disability claims by avoiding freezes, restrictions of overtime. And this is where in this section, I think we have some concerns. We have some concerns about sometimes states have not made their staff available to travel to federally sponsored meetings where SSA is providing all of the cost for travel. Okay. There are many circumstances, and I'm sure the DDSs can talk to you about this at length, where the sync between state hiring authority and federal hiring authority simply do not match. SSA says hire, but the state has a hiring freeze, or the reverse may happen. We see this as a real opportunity in discussing about how a regulatory change might have some opportunity to impact that difficulty. So training. The last part of personnel that I want to talk about is the state ensures that all employees have an acceptable level of competence. It's their responsibility to train their staff. SSA prepares training material. Sometimes SSA will actually provide the training. An example is process unification training done back in the late 90s. It was national training and all adjudicators got the same training. So but it's rare that SSA does the training itself. So some of the challenge here is that the DDSs have all their own training cadres for the most part, and they may modify the training or supplement the training as they deem appropriate.
Melissa,
yes.
this is Jen. Sorry, I don't want to interrupt, but I do want to make clear. So something like a listing update, that training is the responsibility, or at least in your experience, was the responsibility of the DDS as opposed to SSA in terms of talking about the new listing and what was included and training folks on it, correct?
So SSA would provide the training material, but the DDS would administer the training. They would actually deliver it. Okay. We might have video training. I think in the age of where there's been video training that we can release to the nation, we would film it and the DDS would air it or not and supplement it as they deemed appropriate.
Does that help?
Yes, it does. Thank you so much.
All right. So again, the challenges that we see in personnel are the issues of travel when needed, hiring freezes, and training. Those are the three key areas. So for medical evidence collection and cost is the next area. So again, the basics here, SSA provides the funds. The DDSs procure the medical evidence and provides the management to ensure that decisions are accurate, prompt, cost-effective, and productive. States set the rates for medical evidence and for consultative examinations. So the key here is that consultative examination rates cannot exceed the highest rate paid by federal or other agencies in the state for the same or similar type of service. So again, for an example, when I worked in Virginia, it was, if we needed to do a consultative examination, we had to look at the rate the parent agency was paying for a similar type of exam that was based on what the Medicaid rates were within the Commonwealth of Virginia. SSA maintains relationship with national medical groups and organizations, and each DDS establishes local relationships through their professional relations officers. The states recruit consultative examination physicians to work within their state. One of the issues with medical evidence rates, and this doesn't happen everywhere, but there are issues when there are DDSs where claimants may get treatment across the border. And one state may have a particular rate.
Let me give you a real world example, and this might be out of date in terms of numbers, but I was a regional manager for the southwest part of the state of Virginia, and we had plenty of sources that went to doctors in Bristol, Tennessee, because Bristol is split between Tennessee and Virginia. We did fine in Virginia because the state of Virginia paid more than the state of Tennessee. So our requests for MER tended to get higher up in the queue than did Tennessee's.
Right, and that's a problem as we're all trying to adjudicate places for every claimant who applies for benefits in a timely manner. Okay, so workload management, and I think that the key takeaway here is that the regulation states that each state will make determinations for all persons in their state. And that's been, I think, the biggest change over the last several years. Cases are transferred if the state asks us and we agree. With workload challenge, yes.
So I'm sorry, Melissa, just to be clear, it's Jen again. So that's the direction it goes. The state requests the assistance from the agency to transfer workload.
According to the reg, but it has been different most recently, which is what we're trying to emphasize,
Right.
is that our experience doesn't always match up with the regulatory requirements.
Right. I mean, I think that by and large, SSA and the DDSs work very closely and well together to look at where workload challenges exist and to identify methods to help solve workload challenges. For example, SSA can move all cases from one field office to another DDS where nobody has to interfere and transfer a case manually. They just, on the system now, they just move it so that it goes to another DDS. DDSs within a region help each other out as needed. A case may go to another DDS for workload completion. But there are also formalized workload management situations where SSA sits down and says, wow, we really have a lot of cases in state X. We have a lot more capacity in state Y. Might it be good to move cases around? We also have the federal DDS. We have extended service teams, groups that are dedicated towards providing assistance during crunch time.
And I think what we're emphasizing is that the regulation
Right.
should reflect reality.
Right. And I mean, I think it's great that states can help each other out. And I think the DDSs have done an excellent job in being able to develop workarounds to do this. Automated systems now, especially the new case control system, will make it even more seamless to be able to do that. Some of the challenges that exist is, for example, when the federal DDS is assuming a workload for another state, they have to be able to load in all the medical vendors for that state. They have to be able to then generate all the letters that the state would normally generate. They have to be able to pay at that state's rate. So that's a challenge. And again, I think it's more of, as Art says, it's not that the way workload management is handled is flawed. It's just that it doesn't match what the regulation says.
Melissa and Art, it's Kim. Do you know of any circumstance where a DDS has been forced to give up workload?
No, but Since you've spent a lot of time in the region, you know that some really interesting pressure can be put on a DDS to do that, and they have. But I do know of one state, Virginia, when Roland Owens was the boss, that refused to allow Virginia residents to be adjudicated elsewhere. Now, that's a while ago. But again, there's nothing that explains the relationship specific to workflow in the regs.
Mhm.
Right.
And is it a state by state issue in terms of the relationship that the DDS has with its parent agency, with other people, you know, their superiors within state government, in terms of whether their the administration in their states would object or would support, or does that just depend state by state?
Yeah, it is absolutely a state by state issue. The needs in Arkansas are not the needs in Delaware, are not the needs in Washington State.
Right. I think in general, whether the DDS administrators reports directly to, say, the governor of the state or through a parent agency head, I think that may influence some of it. Whether they serve at the pleasure of. I think that's a really good question to ask the DDS administrators when you talk with them today. The other point is, I think that, you know, in the past several years, it has evolved from only having the DDSs transfer cases within the region via a fairly clunky assistance request mechanism. That's a systems mechanism to do it, to the more sophisticated workload management groups now that operate within SSA that will sit down and really have a broad look at truly what's going on all over the country, to have a just-in-time way to move work one place to another, especially with attrition in the states being what it has been over the past several years. You know, I think that the states have sometimes they are more willing to transfer the cases than others. And the difficulty used to be was if a state did an initial claim, they wanted that same state to do the recon as well. It's like, don't send me back those cases you didn't expect me to do your recon. I don't know if that exists now, but it's different all over the country, I think, Kim.
Yeah.
When we began, go ahead.
Go ahead, finish up, Art.
This is our last section, and it will be fairly brief, and then we want to open it up to questions, of course. We started out chatting about the performance expectations and the performance requirements, and that the processing time numbers are way out of date. The accuracy numbers still can work because the outcomes have not shifted very much over time. But there are challenges. The definition of accuracy is measured only on the performance accuracy review, the initial QA. There are many reviews that identify issues, but the only one that's statistically valid down to the DDS level is that QA review. Now, no state has ever been in substantial failure. That's the formal process that happens when either the quality or the processing time numbers fall below threshold for 2 quarters in a row. But no one has ever been in substantial failures. Well, there are opportunities, and it's all important, and it all connects. The regs should have standards set that automatically adjust with experience rather than the current rigid performance numbers. For example, MPT, or mean processing time expectations, could be reset every year automatically based on our experience. We suggest that Subpart Q should reflect knowledge and experience in the administration of the program. While we don't have all the answers, the following real experiences give some issues to be discussed, some lessons learned, and added to our administrative guidance. And these are things like procedures on furloughs when required by the state agency but not desired by the state, by SSA. How do you deal with state spending restrictions on travel and hiring when SSA is willing to pay? How do you deal with federal spending requirements via furlough hiring, medical costs. When SSA has to turn the plug off, how should that impact the DDSs? IT and systems responsibility. As you know, SSA has a pretty robust systems. There have been states that have tried to move the DDS SSA system under state control and support. I don't think it's ever been successful, but nonetheless, that should make some of us nervous. Requirements for background checks and credentialing. Well, that's new. We didn't used to require such things. Now we do because of current federal requirements, but it doesn't always match up with state personnel. MER cost issues, both federal and state. How do you incorporate federal disability adjudication functions? And lastly, when we have a crisis, let's take the opportunity to learn from those crises. For example, what in the world did we learn from the past 2 years under COVID? What did we learn from Katrina and how Louisiana managed their workload after it? What did we learn from 9/11 and the New York DDS that was blocks from ground zero? Those are just our first thoughts to kind of get this discussion going. Melissa?
So it's a couple of things I wanted to tag on from what Art said, and I'll work backwards. What have we learned from crises? During Katrina, that was in the very early days of electronic disability, when they were building a system to have cases, to have an electronic folder where we got rid of the 6-part folder where you turn a page and look at each piece of medical evidence in a folder. Katrina was the first time when we had an electronic folder and we could transfer cases out of the Louisiana DDS and have another state adjudicate them. And I remember looking at claims, and we were able to make decisions to allow pending claims so that they didn't have to wait. It was a wonderful feeling to be able to provide that kind of service to citizens. In terms of the MER costs, the medical evidence of record costs, I think that's a critical piece right now, especially with the advent and the increasing use of health information technology. So currently there's a limited but growing number of cases where when the case is transferred from the field office to the DDS, a trigger is set and records are requested. And by the time the DDS examiner gets the case, they may have records from many of the sources already in the folder. And with that kind of trigger where SSA is triggering the request for medical evidence, SSA is paying for the medical evidence of record. There's a federal rate that goes for that. What should happen in the future? Should the responsibility transition from the states paying for medical evidence, or should it transition to them when it's all health information technology? I think that's a sensitive issue that the states have a vested interest in being part of that discussion with SSA. From a prior hat that I wore with the agency, the discussion about accuracy numbers in the performance regulation, we've had prior board meetings and I've had other discussions where there's just a lot of talk about, well, what does accuracy really mean for SSA, especially when a determination can be accurate, say it's a denial, and then it gets to the administrative law judge and that decision is reversed to an allowance. Does that mean the determination made by the DDS was not accurate? I think there's room there to clarify it for everyone who operates in the disability arena to get a clear understanding of exactly what we mean by performance accuracy, so that we have the clearest definitions possible to administer the program.
Yeah, these regs set the boundaries, set expectations and should set standards. And I think the only way it's going to get done is if SSA and the DDSs and other interested parties work together to make this so. Jean, any questions or comments?
We have a couple of questions from the public, but I want to make sure there are no board member questions at this point.
Actually, I have a broad question. I think, and thank you, this has been very, very informative. And you did what we asked, which was to focus on regulatory guidance and so forth. But my question really pulls back and asks about, have to just reflect about a legislative change. Obviously, federalizing the DDSs have political implications and they have cost implications. But in terms of the kinds of issues you've been outlining, it strikes me as I listen to you, a lot of those would be, maybe all of them, would be pretty close to solved if there was a single, if all of them were part of SSA. And I'm curious what you think, whether you see disadvantages with federalizing, obviously aside from the cost and politics of it.
Well, these regs are built to explain the federal and DDS relationship. So in a very real sense, if it was federalized, it would probably, we wouldn't need these regs in this way. Whether we should or not, that's way past my pay grade.
No, but in terms of,
Go ahead.
Go ahead, I'm sorry.
No. I want to hear what you have to say, Nancy.
Well, no, I'm just thinking in terms of training being uniformity of decisions, hiring, being able to hire staff will be obviously more uniform because it would be federal employees and so forth. I understand that the regulations are to guide that, so I'm sort of moving aside from the regulations, but the issues you've identified as problems or things that really need to be addressed, looking through the lens of the regulations, how would they disappear if everything was federalized?
So let me give you another example from if the DDSs were all federal employees, training might be uniform, but how it's carried out day to day in each individual office might be different. You look at what happens in, for example, when we rolled out a virtual quality assurance system where we broke up and radically changed how cases went from the DDS for the end of line quality review to each of the federal quality review sites. It used to be that, say, the Boston DDS, their cases went to the Boston DQB. You went to the DQB in your region. Well, now cases were going all over the country. And the state would say, well, you didn't review it like my DQB reviewed it. So the point I want to make here is that when you are within one office, within one region, you get your way of doing things. And that's going to exist regardless of whether a DDS is a state entity or a federal entity. So it's, what are the opportunities to make sure that we aren't doing it the Dallas way, but we're doing it the SSA way? And those are, I think, opportunities in other areas to make sure that if we say training can only be the SSA training, or state have to meet face-to-face, because some of those things happen when we become more insulated. I think that's when some things get to be institutionalized in the way your own office does things. And I would say that's the same probably in any field office, in any administrative law judge setting, et cetera.
I'm glad you commented on outcome. And I think by that you mean, why are there dissimilarities between DDSs and other adjudicators in terms of allowance and denial? These regs are silent on that issue because there's never, as far as I know, there has never been any SSA look at comparing DDS allowance to denial rates. It just never has been done. We've certainly all thought about it. and we've all talked about it, and there's been some research done, but the regulations have been silent on it.
Thank you.
I have a question about research, if I may. Obviously, there's going to be differences across states, and the differences can stem from, as you observed, from many different sources. I mean, the fundamental demographic profile of the state from state to state is different. So the applicant pool would be different. The level of basic education and training and so on that's available before SSA training about this particular job. The quality of the workforce would be different. The organizational structure of the administration in the state would be different, and so on. So there are state-specific differences that will never go away. But the research that needs to happen, I think, is to set some baseline criteria for kind of standard differences that you would expect from all of these different differences across states, and then to examine whether there are other factors such as training differences that contribute to disparities in outcomes across states. And that's the kind of research you said both things. You said we've never done this kind of research, outcome-based research. So the question I have is, has SSA actually engaged in this topic at all in terms of their research efforts to discover whether the differences across states are too large or are within some acceptable benchmarks of the differences you would expect to happen anyway?
Yeah, let me just clarify that people don't look at these outcomes in terms of the operational or the policy. There have been some research done, but I'm not sure where it would be that compare outcomes.
This conversation comes up a lot in terms of proving that decisions, say, are repeatable and valid and all those things. There's a lot of, as you pointed out, there's a lot of variables that we would have to consider. Demographics of the state, training, education, things like that. We also need to think about the policy that we use to adjudicate disability claims, policies that allow for subjective evaluation, including such things as evaluating medical source opinion, evaluating claimant statements and how they are weighed in terms of the overall determination, how we look at function in the listings of impairment, how we have to assess those things. It's not surgical anymore. It is not an on and off switch. There's shades of gray in how we adjudicate many of the claims that fall off of the listings. And most of the determinations that are made now, Jagdish, are not made based on a listing of impairments allowance, where somebody meets a listing. It's made based on a medical vocational allowance, where it's a variety of factors that are not black and white, for want of a better term.
I understand that, but there are 50 states and there are millions of applicants, and there are ways, statistical ways to tease out differences and attribute them to certain factors. I mean, there is well-established econometric methodology to do this research. The question is whether SSA has actually taken that step to actually initialize, plan out, and gather the data and do such research. At least I haven't heard of it. And this happens in many areas. This is just one of the areas that I.
Jagdish, this is Jen.
I think that's a great conversation, and I don't have the answer for you today.
Okay, thank you.
Jagdish, if I may, this is Jen. Conway just helpfully linked in the chat to an article in the Social Security Bulletin that does exactly what you're talking about. Outcome variation by state, by impairment type. If you'd like, I'll email that to you.
Okay, I'll take a look. Thank you.
Okay.
Thank you.
Board members, any other questions?
This is
Yeah.
Bob. Kim, go ahead, please.
Okay. In the regulations, I just gave a preliminary scan reminder. And from your perspective, Melissa and Art, it always struck me, working in the area for so many years, that there's so much that the DDSs don't have control over. For that matter, there's so much SSA doesn't have control over. And I'm just kind of wondering, in your view of the regs, is one of the things we need to take a look at, or that should be looked at, I should say. God knows the board's not going to look at that, but the issue of SSA's responsibility in this process as well. Could you speak to kind of how SSA is held accountable through the regs currently, or maybe what needs to change there?
Long ago, when I worked in quality, somebody I worked with said, "Don't those DDSs understand they work for us?" And I would point out to him to say, "No, you don't understand. They don't work for us." In terms of things that SSA should be accountable for, I mean, SSA is ultimately accountable for the DDS performance in terms of ensuring that they complete their budgeted workload, that they achieve, that they don't overspend their money, that they meet their performance goals. So SSA is ultimately responsible for all those things.
But that said, there's no specific performance goal for SSA.
Yeah.
Yes,
I'm
it
thinking-
should. Mhm.
I
Go
was
ahead.
just, pardon my interruption, Art, but I was just thinking about, hiring. SSA tells them how many and when they can hire. It's very
Yeah.
difficult to manage workloads, to manage quality, to ensure you have the right level of expertise and experience when you're strapped and you can't take the actions that you need to take. The medical of evidence, the MER, medical evidence of record budget cap, I don't know if that's still in place today, but when SSA gives the DDSs their money, there is, the administrative budget, and then there's the MER budget. Well, guess what? If all of a sudden they're told, sorry, you've reached your cap, you can't spend any more money, that puts DDSs in a terrible position in terms of, maybe they can't order CEs now, or they, maybe they're recontacting treating sources when there are treating sources. As we know, sometimes there aren't. So there's a number of issues that affect the DDS's ability, to do its job, that are directly attributable to SSA, and yet there doesn't seem to be any give about that in the regulations. If I'm right about that, that's what I'm checking.
There should be.
Right.
There should be. And in our brief notes, we tried to talk about when there's a federal shutdown for whatever reason. I mean, back in '81, when this was done, there really weren't too many shutdowns because of lack of funds at the federal level. Now it's routine. I'd argue that we need to have a way to deal with it in the regs. What would it mean if you can't, if we can't fund you for 2 months out of the year?
Right. Another thing, Kim, I think one thing that's evolved over the years that I think probably has positives and negatives with it is with the hiring freezes. I think SSA and the DDSs have done a lot to evolve and deal with the situation as best they can, in terms of, say SSA gives hiring authority and says, okay, hires have to be committed by a certain date, usually before the end of the fiscal year. Well, certain DDSs may have freezes or may have limitations on the numbers that they're able to bring on board. So the SSA will sit down and broadly look at, okay, who's got the authority? Where can we move that authority to? And a lot of times then that's going to be the state that's going to be able to provide workload assistance when the rest of the country is having a crunch. So there's been, I'm not sure that every DDS would like not to have their hires and then give away some of their work, but there have been some creative strategies to try to deal with the limitations that the states have and the feds have. Yes, it should be clarified in it, and I think there's probably a better structure that could be developed.
Let me give you one other example. What happens if a state is going through a reduction in force and the DDSs as part state are given, with quotes around it, a number of staff to become DDS examiners? This happened to me, and sadly, the staff I got weren't able to do the job. And it really, that means I spent 2 years documenting and taking care of all the personnel issues. And that was work that I don't think I ever needed to do.
This is Bob. At the very beginning of the presentation, you made reference to timelines. And I think, Art, you said that there's 2 decades or something of that sort that we blew past the deadline standards. And as an advocate, that's one of the greatest complaints I get is how long the process takes.
Yes.
So what can we do to be clear about what our standards for deadlines are and achieve them?
Well, you're not going to start from what the regs say because, as you so correctly mentioned, they're really not very valuable. But what if we threw that out and started from what's our experience? What have we actually made this year? And then set a marker, say the average of the lowest quintile, and everybody needs to be above that number. That would, and the point is that if it gets better next year, that mark would change and we'd expect even more time in it. But it would be based on a reality, not something that was set up as realistic in 1981, but not realistic by 1995.
So no other part of SSA, whether it's the end of line decision that the administrative law judge makes or the work that the field offices do to either to effectuate a determination or take an application and transfer it where it needs to go. I can't with 100% certainty say this, but I don't believe it's codified in regulations to say that they must do it within a certain number of days.
No.
And it's only that DDS piece that's in the regulations. And I understand that it's important for there to be some sense of here, we're making this relationship, here's the accountable piece of it, one of the important accountable pieces of it. But I think what Art says is quite correct. Operations, I think this is one of the strengths within operations to be able to truly analyze and dig down to data, all the different parts of the determination process from beginning to end and be able to set goals and benchmarks. For good or for ill, we don't always like it when we're given benchmarks to hit, but I think this is something that operations excels at and can certainly be able to tackle this well. Okay.
Board members, any other questions?
I have a question about health information technology. Over the last several meetings, we've understood that the usage of the share of cases that access HIT is only about 10%, and it's been stuck there for a while. And the bottleneck is the cost of providers to actually sign up for and get the HIT systems into their to work. And it's not an SSA issue necessarily, but do you have any ideas about what could be done to speed up that? I mean, maybe this is a tangential to the particular subject we are discussing, but maybe it isn't. You know, take it easy.
I know a little bit about this. Hold on just a minute. My screen has disappeared. Hold on. So part of it is, and again, I'm not the knowledge expert here, but my understanding, there's costs on both sides. There's costs for a provider And there's cost for for SSA to be able to work with providers to onboard them for health information technology. It's a complicated process where you have to validate that what you would get in paper is going to be the exact same thing you would get in the electronic form.
And that takes SSA staff to do.
Right, it takes a lot of SSA staff to do that. And it's a negotiation with the individual providers. So I know SSA has concentrated on working with providers who raise their hand and say, yes, I'm interested in doing this. And also with providers who are the bigger groups, the EPICs, the other national health.
Kaiser.
Yeah, the Kaisers of the world. Bringing on the onesies and the twosies is more difficult. That, I mean,
Is it cost effective? Is it going to be cost? Is it like a one-time thing and then you accrue benefits for a long time?
I don't know that. I would imagine just like with any other systems, you need to upgrade your systems, but I don't know anything about any of that cost.
Thank you.
You bet.
Anything else from the board? I think the first question I want to ask from the staff's end and the public end is there was a prior system before regulations, and it was, forgive me if I get this wrong, but it was contracts between the states and the correct?
Yes.
Can you talk a little bit about the pros and cons, maybe a little bit of the history of why you think, and we understand, you know, this is a little bit outside the brief of today, but why you think the shift happened and what were the pros and cons of the prior approach?
Well, I was not a fiscal officer at that time, but I can tell you that every year was a complete pain in the butt. It was complicated for SSA through the regions and SSA headquarters, and complicated for the DDS to go through that process of, and again, quotes around regulation. You had to get the states involved, you had to get the parent agencies and the lawyers involved. This seemed a lot easier, and it worked fine. But in my humble opinion, we simply did it and then walked away. We haven't kept looking at it and kept it up to date to reflect our reality.
And why, can you give us a sense of why that is? Why are these regulations sort of frozen in time?
It's not just this, as Melissa said, it took us a long time to do the listings. We're still working on the vocational.
Right.
It's that regulations are important. It puts the black letter meat on the bone, as it were. But that said, it's a lot of work. Changing a reg is a lot of work.
And it would be opening Pandora's box. It is, you know, I think that I've had conversations with lots of people. Yeah, we should open the administrative regs and talk about and change some things. But it's then of when you say, I throw up my hands and I say, what's the point? I'm not sure that we could all ever agree on things. But I do believe that that these are important regulations, just like they're all important. But again, this is the only thing that this is what's out there for the public to see too. And what helps them understand the challenges that we all have on the DDS side and on the SSA side to administer the program. And I think it's important to have it as much as possible to have it be clearly described so that Congress would know, we would know, and the public would know, here's what happens, here's what's supposed to happen.
It would point us all in the same direction, we hope.
So I have a question from the public that's sort of related, and it is, to what extent do you think SSA the DDS this relationship could learn from other federalism models, like, for example, Medicaid. Is there anything Medicaid that the process for Medicaid, are you aware of anything that would inform this and improve on it?
So I a long time ago, I led the Medicaid program for Virginia for the medically needy, run the disability program for that. It was totally hands off from the feds, except for the appeals process. The appeals process was done by a federal, a state Medicaid appeals officer. But in terms of the responsibilities that I had to administer the program, it was, I probably had 1 page of instructions. You adopt DDS decisions. You don't adopt them when they've gone past a certain date. I had no funding. I had no reporting requirements for fiscal. I didn't have performance standards. I didn't have any of those things. Had them within the DDS, but I had nothing from Medicaid that said, these are the, other than the broad responsibilities and a couple of key things, it was very hands-off.
I mean, certainly maybe SSA and the DDSs could learn from others. But we've been in, I'll speak for me, I've been all of my professional life in the disability world, so I wouldn't know of them. But it would be great if somebody was researching and seeing if there's ideas, where are places that there have been adjudicated processes, and could we steal good ideas? Yeah.
So we have another public question. This one deals with the issues around the access to quality health care and how that sort of bleeds over into medical evidence of record, and the need for CEs and all of that. What can the DDSs do within the regulations, their performance standards, guidelines, so that racial and other cultural or socioeconomic disparities do not spill over into the adjudication of claims?
Well, in that situation, you're probably talking about an individual with very limited medical evidence.
Right.
Correct?
Yeah.
And I'll be honest with you, our program requires us to get the evidence that's available, where the applicant has been, to request it, and where needed, to purchase additional evidentiary evidence. We do not purchase diagnostic tests. We do not evaluate for what treatments might be successful with this individual. So I'm not too sure if we're going to ever be able to, in a micro sense, fix socioeconomic need in this program. Maybe I'm wrong, Melissa.
No, I agree. The process doesn't provide care, diagnostics, treatment, any of those things. But in terms of the requirements for evidence to make a determination on disability or not are the same for every claimant.
Now, it does mean, since we can't get evidence that exists, it certainly can be disadvantageous. If I applied for disability, I have lots of evidence.
Right.
But if you don't have that evidence, it's going to be very difficult.
Okay. Where there might be some opportunities is within the consultative examination process to ensure that consultant examinations are thorough and provide a thorough narrative about the results of the examination. And I think that's probably a discussion for another day, but some of that is limited by what the states can pay for a consultative examination.
Yeah.
So I think a challenge there might be to say what opportunities are available to ensure that claimants who need a consultative examination, whether they come with evidence or they don't, and we're just trying to fill in holes with, say, a new allegation, how can we get the best quality consultative examination for this claimant, for each claimant.
Right. I want to check in with the board members, make sure, I'm just cruising through the public questions. If anybody has anything. Okay, good. So we have another question that I believe has been touched on in the context of your answer to our chair, Bob Jundiff, but I want to ask this one specifically to see if we can tease out any more detail. In your experience, how does the difference in policy and practice affect the timing of benefit receipt? Are the automated systems following practice or are they following policy? So in other words, are the systems designed to do it the way it operationally happens, or are the systems designed based off of the policy underpinning the program?
Okay, so I'm not sure.
That's my interpretation. For the person actually asking the question, I apologize if I butchered that, but that's my interpretation.
Okay, so I'm going to reinterpret it to see if this is how I think they're asking it. And when you say systems, I'm thinking automated systems, like say the new disability case control system. And I have never used that particular system, but the way I understand it and most is that say the policy is that the examiner requests evidence from all alleged medical sources within the frame of what the policy and procedure tells us we have to request. And then what we're required to do is use every reasonable effort to obtain that information. And that's defined as following up within 10 to 20 days of request, and then allowing that source an additional period of time to provide the evidence. So within the systems, the automated systems, there are prompts that would alert the adjudicator to, it's time to do your follow-up. You sent the evidence request, it's time to do your follow-up. So that is an example of an automated systems prompt that follows the policy that's in place to obtain evidence.
Okay, great.
What I can recall from DCPS is that, yes, we'd love to make this operationally workable for every DDS, but the underpinning is the policy. We can't have a process that doesn't fit under our policy.
I know that there are systems in process, and I use systems broadly, that are being designed to assist the adjudicator with alerting them to where evidence and policy match up. For example, where a piece of the evidence may say, talking about a specific pathology report in the medical evidence of record, and the examiner may get an alert that says, hey, pick me, look here. This case might meet listing blah, 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 or you may want to look at this pathology report in order to expedite looking at this claim.
That's the Imagine system,
Yep.
right? Okay, so that's Imagine.
A good way to remember this, and lots of, and this is how I train people, there are a lot of shortcuts in this program. There are a lot of shortcuts, but they're only shortcuts to allow. There are no shortcuts to deny. You cannot process that, or should not under policy, process that denial until you've made sure all your T's are crossed and all your I's are dotted. You can allow the second you have enough to allow.
What an excellent, oh, sorry.
I know that DCPS is building in, I know there's a lot of user groups, and again, the DDS administrators can talk to you some about this. User groups that are making requests for how can we help examiners work smart within this new automated system? How can we take advantage of helping the examiner know when they have something that needs to be done with a particular case, because they're getting hit on all sides with hit evidence coming in, new cases to adjudicate, follow-ups to do, evidence to assess, adjudications to write up. How can we help this examiner make sure they follow policy and arrive at an accurate and a timely determination for this case. Again, we're talking about doing the case right, doing it as quickly, as timely as possible, doing it in a cost-effective manner, and being as productive as we possibly can, all to serve, to make sure the DDS does their job, SSA does their job, and that claimants get timely and accurate determinations.
So where you landed on this issue brings up another question from the public. We got a question about pre-effectuation reviews and targeted denial reviews, and whether the heavy weight put on pre-effectuation through the statute and the program integrity piece, and the relatively not discretionary but resource-based decision-making about TDRs, whether that affects an examiner's behavior in terms of looking at an allowance versus a denial. Do you have thoughts about that?
I would say that certainly it's going to affect an individual's how they're going to think about when they adjudicate their cases. Just for some perspective, though, to give you a sense of the numbers. So each DDS on the quality review has 75 allowances and 75 denials selected for review per calendar quarter. That's whether you're Delaware or whether you're California. So that's statistically valid for all the states. It's a sample that's sufficient to make predictions on what the whole performance would be.
For the state.
For the state. The pre-effectuation review requires 50%, and I'm just trying to give some basic information so to answer the question.
Mm-hmm.
The effectuation review requires 50% of adult allowances for Title II and Title 16 and concurrent cases to be reviewed before they are effectuated. So before the claimant gets the notice and before the claimant gets paid. That's about, I don't know how many it is this year, but generally it's several 100,000 cases take up the per sample, where the QA sample with initial claims, CDRs, and reconsiderations is 50,000 or less. The targeted denial review is a review that is discretionary. It's not required by anybody. It's based on a predictive model, just like the per review is. What that means is it takes the history of what happens in the quality review and it builds a model based on, here are cases that have been known to be error prone based on historical accuracy reviews. And it selects the most error prone cases based on this predictive model, and it can be throttled based on the resources available to do the work. Generally, it was set up to do about 50,000 cases a year, but it can do more than that. It can do less than that. So for the per review, most of the errors that come up in the per review are onset errors. So it's the DDS made the determination to allow the case correctly, but they didn't pick the right date of onset. Say they either set it too late or they set it too early. Truly, that's where most of it goes. So the opportunity is there for someone to have the conversation to say, do we really want to focus on onset date and charging an error or just make changes to it? Or do we want to change onset? This would be a legislative change, Nancy, which would say, we no longer are going to consider onset when you apply for benefits. We're just going to pick your onset as the date you apply for benefits. Boy, that would be a political issue. That would be a very sensitive issue. But that would do away with almost all the errors that come up in the pre-effectuation review.
Okay, back to, oh. Are you done, Melissa?
Pardon?
I didn't want to jump in.
No, go ahead.
Because I was going to change the topic just a little bit. You sure you're finished?
Let me just close up to say, to
Okay.
do the final answer to the question is, this is legislatively required. You know, SSI per came about fairly recently. Up until then, we were only doing the per on Title II claims, the pre-effectuation review on Title II claims or concurrent claims. So there would have to be a legislative change on this. There's no out for the agency. I think there has been exploration of using some automated case screening for the per review to to kind of have a big sieve and shake some more out so that they're a way to do some more automated screening of some of these cases so that it would take less person resources to do the PER that could be dedicated to other things.
Okay, before you get in, Ken, let me just say one thing. To get back to the base of the question, if you're an adjudicator and you've got a case that's right on the line between allowance and denial,
Oh, yeah.
could it be that your knowledge that I've got a 50% chance of a case being reviewed if I allowed it, and a minuscule chance of getting a case reviewed if I denied it, is it easier than to deny?
Yes.
You know, okay.
But and I realize I didn't answer that part of your question, Jen. I think targeted denial review has more of an opportunity to change some examiner behavior because there is a larger number of cases that are picked for review than the quality assurance review. And it is a predictive model. So it's focusing on cases that have historically proven to be error prone. And I mean, not unlike the PER review, the focus is on cases with musculoskeletal impairments and mental impairments. So I think that there is opportunities there to change behavior with the targeted denial review.
Kim, you had another question?
I did. I actually have two more questions. Thank you very much for the feedback on quality. There's no question. I think there's a lot of work that could be done there. Not easy, but I think there's some things to do there. You know, and so I was thinking about kind of the basic kind of performance expectations, you know, timeliness, you know, what in terms of how do we, you know, how are there expectations that DDSs are expected to meet when they don't have control? So timeliness directly is impacted by workloads, which they don't have control over, and hiring, which they may not have control over, and money, which they may not have control over, right? Same thing relative to productivity. I mean, typically productivity falls out of a formula that's dependent upon workloads, again, which they don't have. So I'm wondering, as we think about this, you know, the fundamental, you know, what are the fundamental aspects of performance? Maybe those expectations or those standards really need to be looked at in terms of whether they're even the right ones.
I'm going to be a bit sarcastic. If your three premises are correct, then what we should do is say everything's okay and get on about our business, because all we can really do in that situation is the best we can. And if SSA has got that kind of money and nobody is screaming about timeliness or accuracy, heck, that'll be good. But I think the first thing has to be data. When I talk to the board staff, when we talk to the board staff, when we talk to others, it's like getting a standard set of data that everybody has, that everybody looks at about every state and every office within every state. It's just not available. Or if you get something from systems and then you get something from operations and then you get something from policy, the data they've collected are three different sets.
Right.
So it's one of the first things is, what are the performance numbers in terms of correct, quick, cheap, and productive? What are they? What should we be looking at?
Right.
Once we know what we need to be looking at, then you have a chance on setting up, okay, how are we going to say that some people are doing okay and some people need more work?
Right. And I reinforce what Art says. I think with a new disability case processing system, there's an opportunity to dive more into the DDS level data. I know that, you know, if there were DDS specific data questions that SSA had, they had to ask each DDS to report in specific numbers if SSA wasn't capturing the data beyond what was entered at transfer or closure. some of the things at the DDS level, certainly there's a lot of performance measurement that goes on that is within the realm of control within an individual examiner. If a DDS gets, say they get more cases than they can assign, dare I use the word staged cases, where you're not assigning cases until there is room to assign them. And that means that how many cases does each disability examiner get on each given workday? What's the case assignment policy? Once a DDS examiner has a case on his or her caseload, then there's certainly an amount of control that person has. Then that I have to develop my cases within a certain number of days. I have to follow up on medical evidence within a certain number of days. Once I get that evidence, I have a certain amount of time before I take subsequent action on that case. And when I get all the evidence, generally I have a certain amount of time to actually take the next steps. And then it's an individual management performance within that supervisor and that disability examiner of how am I looking at what my disability examiners are doing. And I would say that every DDS does this. And I think the states do a tremendous job at managing the staff resources that they have and helping their examiners be as effective as they can to move cases, to do some of everything every day in order to be able to adjudicate cases. But there are certainly opportunities. But I think a common data, a common sense of we're all going to be looking at the same data set, that these are the elements that we're going to be looking at would be fabulous.
Yeah, and I don't disagree at all. I absolutely agree. And I'm not necessarily saying that to have those kinds of standards is wrong, but they need to be supported by data.
Yeah.
And they need to be looked at, so that there's an individualized approach, maybe based on data. So I think we're on the same page here. The other thing I wanted your perspective on, as the board has been reaching out to DDSs on various issues, we've heard some real challenges on implementing the disability case processing system. And I'm sure we'll talk to the DDS directors this afternoon a little bit about that. But I was just curious about, it seems to me that this was the first time, and I'm just interested in whether what your thoughts are, that SSA really kind of took over such, when you think about how DDSs essentially had their own systems and, through various providers, and could customize those systems and could get those systems addressed on a timely basis. There are certainly pros and cons to that, obviously individualized systems, but SSA made the decision to go forward with the disability claims process. So be that as it may, is your view that the regulations provide SSA with the power to do that? And I think, and what do you, it seems to me that the implementation of DCPS could have the potential to add even another layer of, another layer that needs to be addressed in any revised regulations regarding what's the role of the states in terms of what they're expected to do. And again, what about SSA's responsibility as well? Yeah. Because they had, say, 24/7 support, some of them did. They don't anymore under DCPS. Yeah. So I'm just kind of curious if you could talk about some of those issues.
Well, I don't think we claim to be experts on DCPS and how it's utilized, especially in the last few years. But I can tell you is that these administrative regs are absolutely silent on who has the systems and who is responsible for what. As you know, there were a number of states who have had moves by the parent agency to take over the DDS system and put it under state control. But well, guess what? It's nothing in the regs that say they shouldn't be. That's more, I can't speak to your specific question, but what I can say is that's a perfect example of why these regs need to be looked at and be brought up to the 21st century.
I'd like to chime in on part of the question you didn't ask, which is the impact of having different systems. I believe that, my personal belief is that different automated systems perhaps may be part of whatever research Jagdish is talking about in terms of how does that lead to different outcomes. You know, so.
There is a historical truism, and that is the more we automate, the more consistency there's going to be. That's, I think, true. Now, it's up to the board and SSA to figure out if they like that or not.
Yeah.
Well,
Thank you.
Kim, thanks.
Well,
We have just sorry, go ahead, Jagdish.
While we are on this topic, and it was alluded to again, this paper that Conway circulated goes only part of the way to addressing the issue we are discussing. The bottom line is when claimants are grouped by states, most of the variation in outcomes is driven by individual level heterogeneity within states, and different mixes of impairments in the population of claimants may explain a significant portion of the differences in initial allowances between two states. That does not isolate the influence of state-specific adjudicative and administrative characteristics or differences in them that may contribute to explaining some of the variation. In fact, the conclusion is a great deal of variation in outcomes remains unaccounted for by the models. So there's a next step to be done to this research, which is to add these additional state-specific characteristics in the systems of adjudication. So I just wanted to leave you with that thought. That's all. Thank you.
Thank you, Jagdish. At this point, Spencer's, the board has a hard stop at 11:25, and we have about 3 minutes left. And I know that Diane Brandt, our research director, wants to close us out. For those folks in the public who posed a question and it didn't get asked here, we will do our best to make sure that those get asked this afternoon to the DDS directors to try and make sure everything gets captured. So thanks. Diane, turn it over.
So much, Jen. I want to thank Art and Melissa for joining us. Somehow you've managed to make federal regulations rather riveting. While the regs have had some updates since publication in 1981, you've made a compelling case for additional review. The regs themselves call for periodic review to, and I quote, ensure effective and uniform administration of the disability program. I hope this discussion contributes to thinking about such an effort. Art and Melissa, our sincere thanks. As a reminder, please join us this afternoon at 1:15 as we hear from DDS directors and learn about their experience with disability determination. Thanks so much, everyone.
Thank you.
Thank you.
See ya.
Good.
Good afternoon, everyone, and thank you for joining us today. A short disclaimer, the information presented here is for the purpose of informing the board. The views expressed do not necessarily reflect the views of the board or any board member. We are recording today's session. You will be able to access it on our website, ssab.gov. Questions and comments are welcomed and encouraged and can be submitted via the Zoom Q&A function down below or email to us at events@ssab.gov. You can also tweet us using our handle @SSABGOV. Feedback is also welcome and can be sent via email to events@ssab.gov. And with that, I will hand it over to our staff director, Claire Green.
Good afternoon, everybody. Thank you so much for joining or perhaps rejoining us for our afternoon session on the state agency's role in the Social Security disability process. We've been glad to see the number of people that registered for this event, which may be an indication that folks want to hear directly from DDS administrators. So let me introduce them. We are honored to have with us today Ian Harlow, Director of the Pennsylvania DDS, Mary Wolf, Commissioner of the Texas DDS, Jackie Russell, Director of the North Carolina DDS, as well as incoming Director of the National Council on Disability Determination Directors, or NCDDD, and Leon Scales, the current NCDDD President and Director of the Virginia DDS. A special shout out to NCDDD for their assistance over the last couple of years as the board has looked at the initial and reconsideration steps in the disability process. Their assistance has just been invaluable. Leon has kindly agreed to facilitate today's discussion with the board. The directors have 4 topics that they want to discuss. Each will take a topic, make a short presentation, discuss with the other directors, and then open it up for board questions. And after all the presentations, time permitting, we will open it up for public questions. Leon, thank you. I'm going to turn it over to you.
Thanks, Claire. I appreciate the board inviting us. We have kind of evolved our relationship over the last few years, and we appreciate the interest and the time spent in terms of getting to know and learn more about the DDSs. Again, I'm Leon Scales. I'm the DDS Director for Virginia. I've been in that role for about 12 years now. Virginia is what we call a decentralized state. We have multiple sites across the state. We have 4 regular production offices. We have an extended service team that actually provides assistance to other states. And then we have our administrative office. We're also a state that has a CDI unit for investigating fraud and making referrals to the unit. So we contribute staff there. We kind of lead up the part in terms of budgeting and funding that unit. So we're the flow-through unit for the CDI unit as well. Virginia has a give or take 400 staff at any given time. That includes full-time, part-time, contract staff. Again, we're a state that we probably consider a medium-sized state in terms of workload. We close probably, including the EST, around 120,000 cases a year on average. Again, as far as our organizational structure, we are in with our parent agency, which is rehab. And so I think you'll find that a lot of states are in rehab, but not all of them. So again, and that's our parent agency, so the rehab agency, and my boss is the commissioner for the Department of Aging and Rehab Services. All right, I'm gonna pass it to Ian, and he's gonna introduce himself.
Thank you, Leon. Good afternoon, everyone. Thank you for the opportunity to be here today and share my experiences with the board. I am the director of the Pennsylvania DDS, and my name is Ian Harlow. I began this journey back in February of 2020, a little less than 1 month before the pandemic forced the country into a lockdown. As you'll hear today, no 2 DDSs are the same. And being a large jurisdiction presents its own unique challenges. And it's my hope that these differences and challenges can be recognized and understood by the board, the policymakers, and SSA to help us facilitate a better and more productive relationship between us all. A little bit about the Pennsylvania DDS. We are wholly contained within the Pennsylvania Department of Labor and Industry. Unlike many bureaus in the agency, we have our own restricted office space, computers, and networks specific to our own operation. Right now, our operation is currently about 98% telework capable. We are, like Virginia, decentralized. We have 4 locations or branches, a headquarters, an office in the southwestern part of the state in Greensburg, an office in the central part of the state in Harrisburg, and then an office in northeastern Pennsylvania in Wilkes-Barre. We currently have approximately 700 employees, and we'll be hiring for another 70 in the upcoming fiscal year. And these employees are clerical staff, adjudicators, medical consultants, other support staff, and management. In Pennsylvania, more than 95% of our workforce is unionized. Only senior managers like myself are not covered by bargaining units. So we have 3 separate unions representing our staff, AFSCME for clerical employees, PDA for our physicians, and SEIU for adjudicators and supervisors. The Pennsylvania DDS is also covered by the State Civil Service Commission, And this presents an additional challenge when posting and filling positions for hiring requirements. The vast majority of our work is handled here in-house, but we do utilize a statewide contract for a centralized CE provider, and we do contract with psychologists for psych evals. Our CE vendor typically, just by way of background, does about 100,000 CEs annually. Our targeted workload started off around 200,000 this year, and we'll settle somewhere in about the 160,000, 165,000 cases cleared range. And we were asked about how our MER rates are set in Pennsylvania. They are set by the Secretary of Health. And for our CE rates, again, it's a contractual here in Pennsylvania. So while we originally bid it out using Medicare fees as a basis of that bid, this particular provider came in at about 10% below. Well, but those fees are now controlled by the terms of the contract, and they do permit modest increases. So thank you very much. And at this point, I'll turn it over to Mary Wolf.
Thank you, Ian. Sorry, I'm doing this on a telephone, so I'm trying to make sure I'm unmuted and muted at the same time. We weren't able to join via Zoom in that we are actually working in our office in the Texas DDS. We're not working remotely, and we do not have Wi-Fi in our building. So it was a challenge to get on Zoom, but I was dialing in. That's why you don't see my face. So again, I want to thank the board and guests for allowing us to have the invitation to be with you this afternoon. As you heard, my name is Mary Wolf, and I serve as the Associate Commissioner of the Texas DDS and have worked in the state federal program for 43 years. The last 17 of those years, I've actually been here at the Texas DDS. Texas has the largest centralized DDS in the nation with an operating budget of just over $103 million. We're what's considered a centralized DDS, so we're all in Austin, one location. Our building is about 200,000 square feet of office space. There's an exception. We have 2 CDI units. One is in Dallas, one is in Houston. And the reporting structure, as you're going to hear about a little later, is different in every DDS. And the reporting structure at present is with the DDS is with the Texas Health and Human Services Commission. In my tenure, the Texas DDS has been in a myriad of state agencies within state government here in Austin. Pre-COVID and pre-deployment of DCPS, the Disability Case Processing System in SSA, Texas cleared about 300,000 claims a year. This year, we anticipate we'll clear a little less than 250,000. Our authorized staffing, if we're fully staffed, is about 875 full-time staff, of which 583 should be dedicated disability examiner positions. However, currently our staffing is at 622, and that includes 365 examiners. That means is we have over 200 examiner vacancies in Texas, which of course is the hardest position to recruit and fill. Our average examiner caseload size pre-pandemic and pre-deployment of the case processing system was about 150 cases per examiner desk. Currently, that's about an average, again, it's about 225 cases per examiner. Austin being the capital of Texas, one of the greatest challenges we have is unemployment here is some of the lowest in the nation. Yet our cost of living is the second highest in the nation. Austin has become this hub for tech companies, which has attracted, Fortune 500 companies from all over. Recently, Tesla broke ground for one of their largest manufacturing plants to be located less than 10 miles from the DDS. And they announced recently that they're going to hire over 10,000 employees in the next year for that plant. The average median income for a median home in Austin is $575,000, and the average rent for a one-bedroom apartment is $1,600 a month. I want you to put that in perspective with the annual salary of a brand new disability examiner in Austin, Texas is $38,000 a year. Yet according to the Bureau of Labor Statistics, the fair market compensation for an examiner position in Austin is about $69,000. Which is increasingly closer to the compensation that the federal DDS examiner positions are paid. Staff recently shared with me that the local fast food restaurants here in Austin are posting positions for $25 an hour and offering signing bonuses. So that's kind of where, in a nutshell, a summary and an opening of where the Texas DDS is. And you'll hear more about some of our challenges as we talk later this afternoon. So for now, I'd like to turn it over to Jackie Russell. Jackie?
Thank you, Mary. Thank you. My name is Jackie Russell, and I always like to share that I get to be the DDS director in North Carolina. I'm very proud of the work that we do here at the North Carolina DDS. I started my career with the state in 1993 and have devoted my career to supporting people with disabilities and their families. I've been honored with these opportunities to listen and advocate and implement policies, and I'm thankful for this opportunity to share information with this audience. My statements come from my experience as the DDS director for a little more than 3 years. The input that I've been able to listen to from other DDS directors in this time, and the input from my supervisors and staff, which I regularly seek, and from my leadership here at the DDS. At the North Carolina DDS, we have over 600 employees, and we are centralized here in North Carolina as well. We're the 7th largest DDS in the nation with regards to workload. We will have cleared over 107,000 cases this year. We do not have unions here at the North Carolina DDS. Our parent agency is Health and Human Services. And we were excited this year to engage in telehealth for those allowable areas. And we do engage in that here at the DDS. Those would be CCPEs that don't include additional testing, such as memory assessments and psychiatric exams. Our CE panel here, we have over 650 CE providers. And we also are fortunate to have a CDI unit in North Carolina with which we collaborate. For setting our rates for CEs, we use the North Carolina Medicare schedule to set those rates. And with hospitals, we provide payment using the Medicaid and Medicare reimbursement rates. And I'm glad to have this opportunity, as I said, and I will turn it back over to Leon.
All right, thank you all. I'll just state that we talked with the board in preparing for this session, and we did want to share kind of like the purpose, and the purpose was to help educate the board more about the relationship between SSA and DDS and state government in general. There are definitely things that work well, things that don't. And what we also want to share is that relationship is a very unique one. Our peers on the SSA side are our friends, they are our colleagues, co-workers, much like our peers on the state government side. So again, a lot of that's not about the relationship with the people, but it's more about the culture of their relationship, the history of that relationship, and how that relationship's so key to the success of the DDSs and this partnership in general. I'm going to open talking about that state-federal partnership more in practice. A lot of you were on, I'm sure, for the Spencer's session earlier today. Again, good things there. I think a lot of good questions, good comments. I'll share a little bit of feedback before I kind of get into what I was going to present. I do agree that review, as the Spencers noted, review of the regs is important, but I don't think that that's a critical piece, a critical challenge to where we are at this time. It was noted that there are processing time metrics that that we don't adhere to. Processing time is driven based on a lot of variables that DDSs and even SSA can't always control and hold. So again, if receipts are really high and cases have to be staged, a lot of times staged cases will age beyond whatever processing time goals we have, sometimes before they're even assigned to an adjudicator. So those are things that are often outside the control of the DDSs and SSA in general. So if we really change the reg or change the metrics, it'd be reevaluating something like that on an annual basis to kind of come up with something that was realistic. And so I'm leery of getting into setting expectations that aren't realistic or that may not be realistic for the given fiscal year that we're living in. So those things are, again, it's good to revisit. It's always good to know where you are, where you came from, but we have to be realistic about the metrics and those types of things that we set. There was also some commentary about federalizing the DDSs. Ever since day one for me in the DDS, it was like, that's the magic bullet that fixes everything. And theoretically, it could solve a lot of our problems, but it would also create a lot of challenges. Politically, it would be a firestorm. And we would lose a lot, and ultimately our customers lose a lot, because we as local state agencies, part of local state government agencies, we have relationships with our local communities. We're able to ensure that we get medical evidence. We build those local relationships, and we're able to be effective at those things. We're engaged with the population, so we understand our customer base. The demographics of each state's customer base all varies, and it's key that there are local state involvement in the process. So I think ultimately the customer loses in that situation. Not to mention, the cost would be astronomical. And they're again, in a given time, there are 15 to 20,000 DDS employees. I'm sure there's, our federal government officials don't want to grow federal government roles by 15 to 20,000 new employees. Again, that cost and all those things would just be astronomical. So again, that's just my 2 cents on it. I'm sure my peers may have some commentary later in terms of where that is. And then the last thing I'll kind of, from the session earlier today that I'll add is DCPS, which is our single case processing system. That came up a couple of times. What I'll say is that and again, not everybody has different feelings, but I'm definitely a proponent of a single system. I think from a fiscal standpoint, it just makes sense. It doesn't make sense to essentially have 54 different systems that that we have to support, and financially that didn't make a lot of sense. Also, I think that it could provide us more consistency in how the DDSs go about their day-to-day business. It help for decision making, understanding, workload sharing, all those things. And then one point that Art made earlier was that it could help in a more consistent metrics and in MI. But all that said, we're not there. And the stage that DCPS is today, it's really created more chaos in terms of our metrics, just another layer. It hadn't been refined to the place that we even know kind of what we're looking at and whether we trust some of that and what it means in relation to the similar metrics that we were getting from our prior legacy system. So again, all those things, are ideal. It's in theory, it should work well. In theory, it should be a great tool in the future, but right now we're not at that point. So there are a lot of challenges. So I'll kind of jump right into some of the things I was going to present. The Spencers did steal a lot of my thunder earlier today, and that's fine. But I was going to give a lot of the history in terms of the federal-state relationship. My boss told me on day one when he offered me this job, I interviewed. He said, "Great interview," and I came from operations, and I've spent my whole career in DDS, and so I could just talk DDS great. And he was like, "Excellent interview, maybe one of the best I ever heard." He said, "But your job is pretty much this simple." He said, "You have to massage that federal-state relationship and build relationships and figure out how to kind of make that round peg fit in the square hole." And so, and that literally, it does sum it up. That's kind of like the DDS administrator's job. And it's kind of like massaging that, making sure that things that doesn't always fit nice and neatly, because we have so many places, so many masters we have to serve, so many things that we have to make work, which is really unique to federal government and state government. So I'll start with all DDSs aren't the same. And that's something that not everybody really realizes. We think we just process cases, we have examiners, et cetera. But as we noted earlier when we introduced ourselves, some states are centralized, some are decentralized, so maybe multiple sites. We all have different parent agencies. I don't say all have different parent agencies, most are in rehab, but there's labor, there are a lot of different agencies where the DDS is housed in the states. Some DDSs have unions. Some DDSs, as Ian shared earlier, have multiple unions that they have to manage and deal with. There are they're employees. Some places we have just doctors are employees. Some places they're contractors. Some places they're part-time staff. There are differences in our work weeks. Some states work 40-hour weeks. Some states work 37. Some work 37 and a half. Others work 38. So it's a variety of different work weeks as well. I shared earlier, demographics of our populations are different. Again, some states, have primarily, even in Virginia, areas of our state, we have primarily SSI workloads in some places, and then it changes in other areas. For example, Northern Virginia, we don't have this, having SSI workload as we do in the rest of the state. Some places, directors or civil servants, career employees in state government. Some places they're at-will employees and political appointees. Some places the medical consultants are paid by the hour. Some cases some states are paid by the case. Some states are paid by the action. So again, it's hard to make decisions for DDSs when we all vary so much. So again, I share that information to say that unless you understand how all states are vary, then you can't really wrap your mind around the needs of the DDS and why flexibility is so important. A lot of the rules and regulations that we have are challenging, and sometimes they handcuff the DDSs. It's back to the beginning of this relationship in like 1954. It was a loosely defined relationship then. SSA, Congress decided that SSA pays the bills, DDS process the cases, and it was that loose just to start. And it was more of an agreement. And then, they realized it was a challenge just having that loose agreement. And in the 60s, they tried to massage it further. And, in the 70s, when the workload just blossomed, it was really became apparent that you needed the regs to help govern. So those are the regs that the Spencers were referring to earlier. And that's kind of how we got there. But those regs, it established performance standards for the DDSs, periodic reviews for cases, personalized denial notices came out of that. The goal, again, to improve the accuracy of the disability process. And that was the ultimate goal. But I will say something key that I see is maybe the most important piece to that reg, and it comes in with the objectives of it. And it says to avoid administrative complexity and costs, and don't overregulate the state administration. And those are things that I think has really gotten away from us. If we're going to kind of do anything with regs, I think it's a refocus on what the goals are at the macro level, and kind of back up on some of those things. Because the DDSs have challenges with overregulation when it comes to the DDS workload. To me, I think if we all step back and look at the big picture, SSA should fund, the DDSs should process the claims, and the DDSs are tasked with certain things. And in the regs, it say the DDSs are tasked with their organizational structure, providing staff, staffing their units, providing space, being responsible for maintaining property, et cetera. And again, I think we've gotten that back to that relationship. That relationship has gotten more directive and more, I guess, bureaucracy in terms of the administrative part, as opposed to leaving a lot of that to the DDSs. And I know we're going to get into it later, but there are things such as HSPD 12, that's the credentialing process. That's really a bureaucracy piece that limits a lot of what the DDSs can do in terms of onboarding staff, hiring and training staff. It's at a minimum adds another 6 weeks to the process. I mean, state DDSs are fingerprinting employees, and something I never thought we'd be doing at the DDS. No, we're fingerprinting. We are, completing all these federal forms, send them to units outside of SSA. Those candidates for employment are meeting with investigators and all types of things that, to me, just adds a level to the process that is almost unnecessary. And again, and it's not that security is not paramount to all of us, but the state DDSs and state government, they have processes in place for checking backgrounds and vetting employees. And again, I think if we go back to the regs and we leave that to the state governments, then that's just one less thing SSA's bogged down with. That's one less thing the DDSs are adding time with. It's challenging enough to find employees. I think Mary stated that we try to find employees for DDS examiner roles. And that job is, well, for those of you that's processed cases in the past, we call it the SVP of 7. And that means in DDS lingo or SSA language, that it requires 2 to 4 years just to do that job average. That's a long time to train a person to be able to do a job at an average capacity. And then we bring those employees in most of state government at a place where they're employees who are essentially entry-level employees. And they make $35,000 or $45,000 a year. And that's not competitive. But again, at the state government level, that's where we are. So we need to do things to make life easier when it comes to onboarding, recruiting, and attracting employees. And those things such as the HSPD 12 process, I guarantee every administrator out there will tell you how many of the employees they lost this year because of the length of that process, or because the candidates weren't comfortable with going through the process, or weren't comfortable with the investigators or how it was working out. So again, I think that's one example of how we can get out of our own way and their bureaucracy in the process that doesn't have to be there. The DDSs go out of their way to figure out ways to be an exception. On the state side, they always say, Leon, I know DDS is special. And so there are things when when a state may be in a hiring freeze, and SSA says, Leon, there's 50 hires, can you get them on by the end of October? And so I have to ask for exceptions and explain to the state side why we're special. And I just think that SSA needs to step back at times and figure out ways to just say, no to this, to HSPD 12, for example. DDSs are special. They're exempt from this. They have their own processes. They're tasked with this. And I think those things will make the lives of DDSs easier. And it's more consistent with where the roles are. Because again, it's the DDS responsibility. It's our role to define our organizational structure, to hire our staff and staff our units. So I won't ramble on too long. I'll just add one last thing. It's not on the organizational structure at the DDS level as ours. I think that back to that culture and that the relationship thing at the SSA level, it's such a massive organization. There's so many units, there's so many divisions there. And they're their own siloed units in some ways. And they're tasked with individual pieces of the process, where the DDS is tasked with the whole ball. So we have to figure it all out. And there is each of those units in SSA, they're tasked with managing their bureaucratic part. So policy, dealing with policy. Quality is dealing with quality. Telecommunications, dealing with just telecommunications. And so when there are things that DDSs need, DDS have no voice in order to prioritize. And operations does a good job of advocating for the DDSs, but the associate commissioner in operations is a peer of the leaders of all those other units. So they don't have the leverage to say, telecommunications, we need to make this happen. One example I'll share with you is voice over internet protocol. And a lot of you may not understand what that means, but it's just integrating your telecommunications with your data network. The DDSs reside on SSA's data network. So we have email addresses that are ssa.gov, not the Commonwealth of Virginia. And so we were on SSA's, but we're on a separate telecommunications network, whereas everybody else in the Commonwealth of Virginia, they have an integrated state and state telecommunications and data network. So ours are separate. I escalated in 2009. And again, I wasn't direct at that point, but we were co-locating with SSA field office and OHO. And I suggested at that point, you're bringing in a telecommunications network, a data network for OHO and the field office. Wouldn't it be a good time just to include this DDS, not all of our DDS offices, but this DDS unit? Why are you bringing that up? And the answer we got at that point was DDSs aren't on the schedule yet. So fast forward, 12, 13 years, and DDSs still aren't quite on the schedule yet. And so those types of things are, in this day and age, simple to make happen. it shouldn't take 13 years to get, or make voice over IP available for the DDSs who want it and who need it. And those things were evident. I think the pandemic exposed a lot of things as we transitioned staff home to telework. We didn't have the telecommunications access, whereas an SSA employee could go home, telework, plug a headset in, take their phone calls, et cetera. DDS employees ended up with workarounds. It's cell phones and limited function cell phones back. So I just think that having that DDS voice, understanding the relationship, figuring out a way to ensure that DDSs have a true voice in terms of what matters, and not having to be so reactive like we were during the pandemic stage. So I'm not going to ramble on much further. I'm going to stop. And what I'll do is pass along to Ian, let Ian open with his session, and then we'll go from there.
Actually, Leon, this is Jen. We have a couple of minutes left in your block. Should we open up for any board questions before we hand off, or do you want to just keep going?
I'll take questions, but let me offer an opportunity for my peers to add anything that I may have missed, or other relevant examples. Because what we want to do is not necessarily each of these blocks be just Leon's block, but also make it Leon introduces it, and then if there's time, then my peers can also add anything they have in that area.
Great.
So,
Great.
okay. Hearing none, we can take questions.
I have a simple question. I mean, I understand there's a lot of challenges, as you've described, in getting these relationships to provide a good working environment for where you can do your job and achieve your workloads and so on. You've listed a lot of things, and this is very helpful information for us, of course. But are there success stories that you could cite where this relationship has worked as it's supposed to, that has led to the proper outcome in some cases, or where you raise problems at all?
Definitely, and those are things that's any situation where the challenges are the things that are most often shared, because the things that work in world you don't need to always talk about. But I'll use the example that Art and Melissa shared this morning in terms of Medicaid administering that unit. We're responsible in Virginia for Medicaid, and it's light years away from the way SSA provides support and guidance to its program. They interpret the code, they provide POMs, constant updates, lots of budget support, communication. So again, all those things are done really well amongst the DDSs. They support the program well. We communicate on a daily basis about everything DDS. And again, and it's just more that the challenges often kind of outweigh the things that are good. But the programs work, and I think that they have strong oversight. They're involved. It's not like an absent oversight process. So again, I think that's definitely a huge success.
The reason I asked, I'm sorry, you wanted to go ahead, Jackie? You're muted, yeah.
Yes, I was just going to add an additional example of success with that collaboration. In my observation is with how we support our claims for people who are homeless. We've worked closely with our SSA ADO office here in North Carolina, as well as local supports in processing those claims, as well as supporting those claimants and getting to doctor appointments. So it's been a real strong relationship. That's just an additional example I wanted to offer.
Great. I just want to say in closing this question, the reason I asked is, I don't know if anybody's done some work in comparing success stories and why they were successful with problem areas, and seeing why there are problems in solving issues that you might be bringing up and getting a deaf ear from SSA. Someone needs to go through and do a comparative study as to this thing worked, this is why it worked, something is not working, this is why it's not working, and are there any lessons we need to learn from the success stories to bring them over to the problems at hand. And I think SSA should devote some of its research to this topic in order to solve these problems. So that's why I brought it up, but thank you.
Yeah, it's good, and I'll share the more success areas. SSA facilitates the National Disability Interest Group, and that's an area where we have constant communication about challenges, and we solve a lot of problems and have a lot of good dialogue there. But again, it kind of goes back to once we identify and things that we can't solve, it's like where's that DDS ultimate vote? So again, I think they do a good job of helping DDSs identify, and we discuss and talk about a lot of things. And I think those are things that we do well. But you know, there's sometimes like the follow through, or where's the DDS vote in terms of prioritizing these things that need to happen and the timeliness of those. But again, they put a lot of good tools and processes in place, and the communication is done well in general.
Yeah, I've got two quick questions for all of you. I'm Nancy Altman, board member. And first of all, I want to start by I'm finding your remarks so far very compelling and educational. So thank you. And thank you for all the work all of you are doing. One question I have, which I also asked this morning, if Congress were willing to federalize the DDSs, it sounds like there would be some advantages, some disadvantages from what I gathered from your remarks, but how would you evaluate that? Would that, I mean, it might make recruiting easier, the salaries would be higher, but you might then be part of a bigger bureaucracy. I mean, how do you hear that and go, ooh, that would be great, or, oh my gosh, I hope they don't do that, or it could be better, it could be worse?
I'll say, similar to what I said earlier, 20 years ago, as a young examiner in the DDS, I was like, why don't they do that? You know, Leon gets paid more, things would be easier. And yes, I think some administrative things could be streamlined and a little bit easier, but I think ultimately the loss of the local relationships in the communities, I think those are things that you couldn't duplicate with a federal unit. And I think ultimately that gets back to hurting the customers. I think you probably lose a lot of those local relationships, trying to get evidence and turn around things fast. It's paying bills, for example. We've talked over the years about whether we, in our MER process, whether we have a national vendor file and what, again, centralized pay would look like. But those things are challenges when you're trying to deal with get evidence from local communities. For example, if I have a MER provider and the fiscal process has delayed that payment, at a local level, Leon or our professional relations office can make sure that MER provider gets paid. They can call up and they can contact our fiscal section or our state account section and make sure that happens today. Hey, this you missed this. This person, we owe them this money. When you turn this around quickly. And those things are why we're successful at getting medical evidence, because we can turn those things around quickly. We can satisfy anything in those little challenges, where if it's this massive federal process, then I couldn't, there'd be no one for me to call at SSA and just make this payment today. Nothing in that bureaucracy happens today. And that's one of the challenges that we have. Mary Wolf told me some years ago when I early on took this job, she was like, the difference is with the DDS and SSA is that when we see things happening in our DDS, when we see something's not working well, not going well, we fix it today, and sometimes late, maybe tomorrow. And when there are things that's not going well, that maybe on the SSA side, there's nobody that's gonna be to pick up that phone and say, pay this bill today. It's not gonna happen that way in that SSA machine. So I think the customers lose in the end. But that's, again, obviously it needed a formal study. That's Leon's informal opinion. But
so Leon, if you don't mind, in order to keep us on any kind of a time, I think you do need to hand off to Ian at this point. Board members, if you have questions related to Leon's presentation, I guarantee you there will be time. We just need to hold them for the moment.
All right, Ian, it's all yours.
Thank you, sir. Thanks, everyone. So I'm going to cover personnel actions, and I'm going to start off with hiring allocations and how they impact state DDSs. From a very high level, the process works and authorization is given from SSA we all have to go, or most of us have to go back on the state side to get approval from our state parent agency to increase our complement. The positions are posted, candidates are selected. The HSPD 12 process would kick things off, and then eventually, when that's all complete, they would begin, the new hires would begin work. And so I start there because as I work through this, I wanted to give you that basic background. You know, in most cases, and I have not been in this position as long as some of the other directors, but in my experience, you know, I've had till the end of a fiscal year to fill positions. And, you know, for Pennsylvania, SSA has been very generous with the positions, and we've gotten a lot of hires in the last year and a half, and they've served us well. But you know, during the pandemic, for example, I had to go to my parent agency because we were a hiring freeze, even though these are federally funded positions, and you have to seek approval. Well, that just adds on to the process. And you know, while we were able to acquire over 100 employees in the last fiscal year, which, as I mentioned, is outstanding, Pennsylvania at that same time lost about 50 employees. And so the way the allocations are given by SSA, when someone leaves, that person comes off of your complement, and your complement trickles down until an additional allocation is given. So in my case, I received 100 last year. During that same period of time, 50 of my employees have retired, separated, et cetera. So my net gain was about 50. So I say that to kind of explain the process. And what happens usually, the two never balance out. And like I mentioned, I was very fortunate. I had the positions awarded to Pennsylvania, and sometimes we DDSs will go a couple years before new positions are awarded. So as we're waiting for those allocations to be awarded, our current complement will tick down. And when our complement ticks down, it's less work that we can do. We have less people available to process claims, et cetera. And then all of a sudden there's a surge of resources that come in, and we've got to stop and take time to train them. And that, you know, by the nature of our work, it's complex. And in Pennsylvania, our training program is 2 years. It starts out with a 6-month probationary period where it's a virtual now classroom training where it's day in and day out. Our new hires sitting in a training environment, and our trainers and staff members and physicians are working hard to educate them on the requirements of the job, the how to review a case, how to use the system, how the organization works. And, you know, what I described is a really good situation where we have the entire fiscal year to make these hires. Sometimes, and we, all of us in government understand this, you know, budgets end up being a little bit different mid-year, and we're given the authorization to hire, but we've got to fill those positions, as Leon alluded to, you know, in pretty short order. And, you know, that's a challenge for us. And so many of our colleagues have, you know, would like to see a more stable or predictable hiring approach. And there are other aspects of the hiring process that create challenges for the states. And again, Leon touched on a lot of this earlier with the HSPD 12 process, right? You know, that adds a considerable amount of time to our hiring. So there's a 6-week time frame for us to send what's called a mass initiation spreadsheet to SSA, and then they do their work, and there's interaction between the new hires and the HSPD 12 folks, and ultimately what you're looking at is in some cases an 8 to 10 week process before from the time an offer is made until someone can actually show up at your DDS and start performing, or at least start the training program. And This, that time frame obviously takes, it's complicated. When you're doing a training class, you need people to start at approximately the same time. And that process also makes start dates a little less predictable. And we sometimes have to delay classes until we can get all the students in, because we're obviously not going to start a training program and then restart or go back and do different pieces for the folks that missed the first or second day. And, it just presents a lot of challenges. In addition, the way the process works, when SSA rejects a sponsor request under HSPD 12, we're not always notified. We've got to monitor our staff, the DDSs, have to monitor the queue to try to make sure that, nothing gets by or any of those rejections get by. And there's no automatic system to notify the DDS that an individual has been released an EQIP package, which is the package that they need to complete to go through the HSPD 12 process. And again, those we are working with SSA to get some automation built into that process, or requesting it, because that monitoring just slows down the process. And if we miss it, it just delays the process. And last year, for our last round of hires, it was between 10 and 12 weeks before they started. So it was a real challenge for Pennsylvania. And as I mentioned in my introduction, we have 3 labor unions representing our employees. And the probationary period that a new hire gets is governed in part by the union contract. And so because of the delays that we received from the start dates, we had approached the unions and said, hey, look, we would like to extend the probationary period by a period of 8 weeks. And that will give us adequate time to review people's progress, the new hires' progress, and ensure that they are meeting the requirements of the position. And that what we didn't want to do was review them at a point in their training when it was really too early to tell, or we wouldn't give them enough time to make a successful transition to the next phase. And that's why we asked for the request. However, and just one example with the union, the union would not agree to those parameters, and the Commonwealth had to make determinations on people's progress way earlier than we had to. And at the end result was our class in the last year was much smaller than our previous versions. And while some of our trainees resigned, they left on their own, we had to make a decision based on the information we had. And so our previous retention rates for training classes were somewhere in the 78 to 81 percentile. So 78 to 81% of our new hires would make it through the training process and complete the probationary period. Last year, and obviously the pandemic played an important role in this, last year we were struggling around the 60, 62, 65% mark. So this obviously has a huge impact on our operations. In addition to those delays, the next part of the process would be when a PIP card is issued to an employee. And for a DDS, if we're working on site, that's not necessarily as big of an issue, because as long as the new hire is within our building on our network, they can have access to the computer systems and software. However, because our offices were closed due to the pandemic, everyone needed a PIP card to access a laptop and a VPN network. And so that was another delay that we had to wait for and accommodate with all of our training. And I say this not to be critical, but just to explain the complexities of the multifaceted process that we use in hiring. So we get authorizations, lump sum, all at one time. There's a very complicated process to post and hire the positions in the state. We've got to complete the necessary background steps for SSA, and then we've got to train these employees. And it's would be much easier if we were able to keep our allocation, much like we do on the state side. So for example, if your complement is 100 people and you have 10 vacancies, meaning you have 90 seats filled at this point, you always have authorization to hire those last 10 people because you have a total of 100 positions that are fully funded on the state side. So, you know, something like that would certainly be better to see on the federal side. It would give us a ability to plan a little better, more long-term. We would have succession planning. Our classes could be smaller and more tailored to training. So, you know, under hiring allocations, and I'm kind of getting into training a little bit, but you know, those allocations lead to a lot of different things down the line. So it would be helpful if we could work on that. But again, Social Security Administration has been very generous in Pennsylvania, and we appreciate the allocations that they provided us, but perhaps there's some room for improvement in there. And, you know, there's, along those lines, we have recruitment and retention challenges. The adjudicator position is a very demanding position. There's no real college degree that lends itself to the combination of medical and legal knowledge that is required for the position. Recruitment, as I mentioned, is not easy, and most people really don't even know what an adjudicator position is or what they do. Retention for our newly hired adjudicators can also be a challenge as the job is demanding. And new adjudicators sometimes quickly realize that the position is not for them. And we think that that's what happened and was exacerbated by the pandemic last year, which is why we had a lower retention rate. The vast majority of our dropouts do resign versus being cut from the program, so people self-select to remove themselves from the program. And in particular, as I mentioned, in Pennsylvania, that program is a 2-year training program. We do tie pay increases to completing different periods of the training program, so that does help retain some folks. And now that we've been offering telework since March of 2020, we have seen some improvements in recruitment for our positions. And that actually is very true. In Pennsylvania, our medical consultants are state employees and are hired in-house. So we see that benefit us in terms of telework. In regard to working with unions, if you're not from a state that has a strong labor presence, these things may be obvious to you, but we have a contractual obligation to have our unions at the table for certain aspects of our operation. And that contractual obligation, while not necessarily bad, it just adds a step to the process, to an already complicated relationship between us, the Social Security Administration, our parent agency, et cetera. In Pennsylvania, we find it helpful to have and have set up regular meetings with each of our unions. They're called meet and discusses. And we have those meetings because it allows for us to suss out, if you will, some of the issues before they become issues and turn into something larger. They're a great opportunity to deal with some of the problems on the table before it leads to any type of major disruption to work. And, you know, just in short, we need to be proactive in getting input from the unions. That's an approach we've at least taken here in Pennsylvania. And because remember, they are, at least in Pennsylvania, entitled to be part of that process. And we find it generally to be a good idea to keep them informed on kind of some of our thinking, things that are kind of coming down the pike. You know, but there's also the grievance process. From time to time, employees through their respective unions submit grievances when they feel as though there's management has handled something unfairly, work is being taken away, and that triggers in Pennsylvania the accelerated grievance process, which is a 5-step process that ultimately can lead to arbitration if necessary. Obviously, most things don't get there and they're resolved locally, but that could sometimes occur. A couple recent examples of this, as Pennsylvania has been converting to the DCPS system, there are what are called exclusion cases, or cases that cannot be processed within that system. These are very unique and kind of one-off cases. The plan from SSA was to ship those cases from Pennsylvania to the Dallas DPU. We had a conversation with our labor unions, as we're required to do, and the labor unions do not want to give up the work. So we're working with them to trying to find a way to keep that work in-house and satisfy the requests of the unions. The labor unions have also had input in telework. They have input anytime that we change performance standards, whether it be for examiners or adjudicators or our medical consultants. And, you know, they've even raised concerns regarding DCPS versus our legacy system, whereas they feel in some instances work takes longer to process under the new system, and therefore lodge complaints about that. So it's just a host of things that in Pennsylvania is part of the process. They have a seat at the table and we deal with, but it could be a challenge, and if it does anything, it certainly adds time to whatever process that we're trying to work. Next, I'd like to talk a little bit about the new examiner training and learning curve. You know, again, I've touched upon some of these things. It takes several years for adjudicators to be fully trained and up and running. This job is very, very complex. That's why having positions allocated on a yearly basis to replace retiring adjudicators is vital. Waiting for every 2 or 3 years puts the DDS behind. And since it takes a lot of time, as I've already described, to hire adjudicators and train them, working at that level would certainly provide better outcomes for the Commonwealth and some of the DDSs. Generally, adjudicative work or examiner work is becoming more complex. MER is increasing in volume. I remember when I first started in this position, having a meeting with my staff, and we were talking about different things. And for those of you who don't know, that I'm not of the disability determination background. I came from another state agency, and I was being briefed as to what adjudicators do. And one thing that one of my staff members said to me, it really stuck with me. It's like they're physicians and lawyers without the associated degrees. That's the type of work that they're doing. That's the level of detail that they need to put into this. And that's why it's so hard to retain them and so hard to train them. And finally, in terms of new examiner training and learning curve, and this would even fall under program complexities, you know, caseloads are generally increasing. And sometimes that ebbs and flows as it relates to our hiring allocation, but that does pose a challenge to us as well. And finally, you know, program complexities, we've somewhat discussed this ad nauseum between Leon and I, but, you know, DDSs are all different. We're certainly not field offices. In addition, you know, to everything else that we're doing, we've got to stay on top of POMS, policy, make sure we're getting back to our DPAs and others asking us for questions. You know, we're responding to audits conducted by SSA. We're also doing a lot with quality to make sure that our operations are meeting those targets as well. It's a juggling act, and there's a lot going on. I think that you know, we're doing a lot of good work, and our staff is doing a lot of good work. I'm certainly proud of the work that Pennsylvania is doing, and especially in light of the pandemic. You know, we've got our CEs back online shortly thereafter. They were opened back up last year, and it was a challenge, but we've converted in part to DCPS, and we completed an audit and a financial audit and a security audit. So I'm very proud of the work that we're doing, but we're constantly balancing that. We're dealing with you know, all of those things, and normal workloads, normal quality issues. And then, all right, well, let's hire 100 people, and we've got to do this, and please comment on that. And it's just there's a lot going on. Our folks are good at what they do, but they're taxed very, very much at this point. So Leon, I would turn it back to you. That concludes my presentation. I'd be happy to take questions.
All right. Thanks, Ian. And a couple of things I would add to some of this. Long before Ian's time, NCDDD had a staffing proposal to SSA, and it's essentially what we call like a hiring ceiling or hiring floor even. And it was basically that it may not right size the DDSs who are understaffed, but at least on an annual basis, they would have a staffing number and they would manage that number. Because again, if you think about it this way, if staff never turns over or minimal staff turnover, then SSA is paying the freight for that personnel. So again, why not create those and again, let the DDSs manage to that without having to wait every year on SSA to say go. And again, and that's been something that the Office of Budget has just been reluctant to support over the years. But again, that's a great point, Ian. And then one other thing I'll say is that he really nailed it with the staff is taxed right now. We had an NCDDD board meeting just a couple of weeks ago, and it surprised me. I thought it was Virginia, but across all regions, it was like, morale's down. And I know that the pandemic, that's just part of it, but it's just challenging. We're trying to transition each state from legacy systems to DCPS. And again, while we support DCPS and we think it's going to have some great potential, today it's not as effective or efficient as the system they were using. And so they feel like they're being handcuffed with that. And so again, it's just, so we definitely have some turnover directly related to that. And I heard that every state is having those same type of morale problems. And what happens, with DDSs, at my level down to the examiner level, it seems like things are forgotten really fast. That that they're dealing with the pandemic, they're at home learning to telework, they're transitioning across two systems, and all these things are happening. But then we still always ask, well, what about your performance? And I told SSA not long ago, I said, if you're gonna tie both hands behind my back, then don't ask me later why I'm running slower. And so, and that's literally where we are with some of those things. It's impacting, retention and recruitment, et cetera. Any of my other peers have anything to ask before we take questions? Anything to add? All right, here none, we'll take questions.
Well, I have a question for all of you, and that is, both of Ian and Leanne, you both mentioned the pandemic, which of course is on all of our minds, and you've talked about worker morale, and of course that is so crucial, of course, to productivity. You want to do everything you can to have as high morale as you can. And Leanne, I think as you mentioned, and we've seen this in all kinds of areas, that what the pandemic has done is really shined a spotlight on issues that were festering, that were already there, but they just got exacerbated often with the pandemic. So it's just kind of a general question, and that is, lessons learned, things that, and then in terms of the morale and the issues there, whether there's anything that SSA can and should be doing to really support your workers and to help.
I can go. Oh, go ahead.
Hey, Leon, this is Mary. I was just going to say, I can speak to that, but I'd rather defer till I kind of give my testimony, because I think I speak quite articulately to some of that. So that's why I haven't chimed in on some of this, but I think we have some answers for you and some input.
Yeah, glad to anticipate what you're going to say. So that's great. I can wait.
And I'll try not to steal into Mary's thunder, but I'll just say that like the pandemic definitely did shine us a light on a lot of different things, and that's back to where does the DDS voice really land, and where can we really influence the process, back to that relationship thing. Again, like I shared, that I know that the associate commissioner and ODD understand some of those needs, but he doesn't have the power to provide us laptops, or he didn't have the power to implement voice over IP. And so those are things that have been on the radar for long periods of time. But we don't always, ODD don't always have the last say so. And so again, so where is that voice and that understanding? Again, back to talk about the relationships, not the individuals. It's like the culture of where DDS fits, and how do you prioritize those things when DDS a lot of times is not at the table. And so we've been ringing the bell about laptops. We've been ringing the bell about just telework in general for us as a recruitment tool, retention tool. And again, it was hard to get to that point. We had a pilot going on that would probably still be happening, with just a couple of states had it not been for the pandemic. And then, the pandemic, kind of shine a spotlight on things, and we were almost able to telework overnight, albeit taking, desktops home with the employees. But again, we were able to make it happen. So I just think some of those things where there's a willingness, there's a way. And I think we have to be more proactive and figure out how to get the DDS force, I guess, heard more effectively and more promptly at times. And I think it's easy to be out of sight, out of mind when DDS is not sitting at the table in those meetings in central office or wherever.
Well, actually, that raises an important question. We also, as a board, have been looking at IT modernization, and there's a lot of discussion at SSA, and something we see everybody sees the value of it, important of not just having technicians off by themselves, but really talking to operations, talking to the various components, and making sure that what they're doing really fits the needs of the work that's being done. Are you part of those? By you, I mean DDS. Are the DDSs part of that conversation, or have they reached out to you about what your wants and needs are?
I will say yes, but I'm not sure where that is. And I'll say that I know that myself and Judy Spear, who was the former California director, are actually members of the group on IT modernization.
Oh, great.
But again, the movement on that, and I can't recall the last meeting where we were an active participant, but again, we are representatives on that group.
At least you're not totally forgotten. I don't know where you fit in that, but that's good to hear.
This is Ian. Can I just make a point on that, please? The pandemic really taught us a lot of lessons, right? For me, it was only 3 or 4 weeks into my tenure, but as Leon mentioned, we were in Pennsylvania on March the 12th when we shut down the office. We had about 70 people with laptops, and the other 600 had desktops. So we're struggling to get towers out to people's homes, and they're running Cat5 cables through their living room and kitchen to connect to their cable modem in a bedroom. And, it was just a lot of chaos. And part of that was in the moment. We, all the COOP planning that we've all done, we never planned for something that would shut down an entire state for a long period of time. But one of the things that I found to be a challenge was that, for voice over IP, for example, it was interesting to hear Leon say that they'd been working on that for 10 or 12 years. I made the same request early on in the pandemic and said, hey, look, we need to open up telecommunications to our folks at home. We had an antiquated analog phone system in the office, but now that everyone's remote, what options do we have to use Skype? Because, my previous tenure was with another state agency, and my laptop was connected to my Skype. I had a cell phone. I could work and communicate from anywhere. And I was really taken aback by how limited the technology was at the DDS. But what ultimately ended up happening, Skype wasn't available through SSA, and as you know, we're on their network and we have to use their equipment. And so we sat down with our state IT resources and said, hey, is there any sort of bridge that could we do? And we got with the federal IT resources, the SSA IT resources. And long story short, we tried a couple of things. It didn't work out. But that left the DDS in a very, very bad spot because, we were pretty much operational minus our phones. And what we ended up doing in Pennsylvania was we worked through the state side of the house and we ordered 600 cell phones. And so every employee in Pennsylvania has a laptop now that SSA provides, and the majority have cell phones from the state of Pennsylvania. Now they can't access email, SSA email through them, et cetera. They're very limited, but it allows us to, for our staff to make and receive those calls. Plus, each one of those cell phones is a hotspot. So, God forbid, someone's internet connection happens, or we're in another pandemic, they can work remotely. And I say that just to illustrate the example of, we had this challenge. The resources weren't available, and we had to move on and try to build something a different way. And I think that that's history now. But I think the important part is taking all those lessons learned, incorporating them, and making sure it never happens again.
Yeah. Being more prepared. Yeah.
I hate this job because it makes me the not fun person in the group, but I have to remind everybody that we are out of time for this session. But board members, please, I promise those who haven't been heard from yet, you will be heard from soon. But Leon, I just wanted to let you know.
All right, thanks, Jen. And we'll, at the end, if we have more time, we'll try to get back to any of those questions. I know Mary has a hard stop, but some of us could probably stay on a little longer if we need it. All right, next up, Mary.
Thanks, Leon. So I've been asked to speak today about workloads, what that entails, the challenges with processing workloads, projecting, managing, budgeting, sharing, and how the case processing systems have also impacted workloads. And it's my hope that what you'll hear from my conversation with you today is a lot of what's been talked about, and maybe with a little bit more detail in some of the challenges that we face. But as everybody's already said, we're very fortunate to have the dedicated staff that we have on both sides, at the state side and the federal side, working towards the same mission, which is serving the American public. I mean, this responsibility to manage the program is just overwhelming. Serving the citizens that we serve, they look to what we do, usually in a time of great distress and vulnerability. So the responsibility becomes very personal to a lot of our staff. To manage workloads during a normal time can be challenging, but you add the pandemic and all that involved, you add staff turnover, retention, the deployment of a new case processing system, suspended workloads, lack of medical sources, and you can just see how the challenges become multiplied. So as you've heard already, that there's no two DDSs really alike. So when trying to project workloads, that uniqueness has to be given really due consideration. At times, it seems that SSA experts assigned to assist the DDS overlook the critical piece and consider the DDSs as all equal, and they deliver directives or messages that become problematic for one state or another. So for instance, if half your workforce has less than 2 years of experience, kind of like you've heard, or you lack adequate medical resources, or your overall attrition climbs monthly, you just can't expect that DDS performance and quality to be the same as a DDS who doesn't experience those same things. Considerations to the impact of the national pandemic, the deployment of the national case processing system during that same time frame, coupled with the extreme weather events that many of us had, hurricanes, winter storms, that rendered your operations completely shut down, gave reason to pause and regroup and really come to the table to communicate that one size doesn't fit all. But we haven't really been successful yet at that communication. When DDSs begin planning and projecting annual projections, adjustments no doubt have to occur during the year. However, what is often lost is when you make adjustments, it's not just as simple as modifying a spending plan updating a report, DDSs have to consider the impact of any modified projections on their staff, as well as how those modifications may impact the state, who also requires performance reporting from a DDS. So DDS staff career promotions, performance plans, and other state-specific personnel measures are all tied to performance and are all impacted when projections have to change. As we look to close out fiscal year 21 and we look at what 22 is going to look like, we wonder, as everybody does, what does the new normal look like? Not only at the DDS, but in our personal lives, because that's going to impact our workforce. In many states, certainly in Texas, our state has authorized a very generous leave for employees who are impacted by COVID. Some staff have been out with COVID-related incidents for multiple months at a time, not returning to work, or some returning only to be back off again. So if we only have a few weeks left in this year, as shared earlier, 21-year performance is going to take a hit, mostly but not totally due to the pandemic. As we look toward 22, it's really hard to determine what capacity we're going to be at. The projections are going to depend solely on the uniqueness of each state. Some states are open for business and seeing minimal COVID, while others remain closed as their COVID numbers continue to increase. I said to somebody the other day, what we know for sure about 22 is we know nothing for sure. That's how I look at 22. Most DDSs now have received information from SSA, as Leon mentioned, kind of what the projections are going to look like for us to produce in 22. Their projected numbers at first glance appear unrealistic in a perfect world. You add all the things we've talked about, the unprecedented staffing losses, the ongoing unknown impact of the pandemic, the deployment of the case processing system where, as you've heard and we'll talk a little bit more about, workarounds have become daily requirements for each DDS to address. There's no doubt that the numbers recently projected by SSA, at least for Texas, are going to be impractical. There's no way we're going to be realistically able to perform those numbers. Now, DDSs understand better than anybody, and we support the responsibility we have to workloads. However, there has to be a point in time that a common sense approach and a mutual, not one-sided negotiations have to occur so that we can all talk about how workloads can be addressed. No, we can't reasonably ensure the impact the future events are going to have on our program, but we can and we should work together to mutually collaborate on processes that make sense holistically based on circumstances and partnerships. I'm going to give you an example, which I realize is state-specific, but I think it'll help illustrate the importance of advanced conversations and why collaboration is so necessary. Texas DDS lost about 12 staff a month this fiscal year alone to attrition. You add that attrition to the national emergencies, and it's clear workloads are going to be impacted. When you experience attrition, for whatever the circumstances, the DDSs have to consider the priority of the workload assignments. Essentially, we have to know who do we have that can do the work. And the important factor in that workload planning are, as the types of claims a DDS can work are dependent not only on the total staff we have, but more importantly, the experience of those staff. DDSs have to consider, do I have staff experienced enough to work initials, recons, CDRs, etc.? And what is my capacity level for working each of those claims? Generally, DDSs have capacity for initials and recons, but unless you have tenured staff who are trained in CDRs, the CDR workload is probably going to be impacted. Now, rightfully, and we can all agree, CDRs receive a great deal of attention and interest by SSA, the public, to manage them efficiently and timely. We don't disagree with that. However, managing that workload is one of the greatest balances in a DDS that has excessive turnover of tenured or qualified staff, as they're the ones that have the knowledge base to work those CDRs. So I can tell you, we receive inquiries from constituents and their advocates regarding the status of a claim daily. Very seldom will I ever get an inquiry about a CDR. They're not calling me about that. They're calling me about that initial decision, and that decision, the recon decision, because it's delaying the ability for that individual to get some long-awaited medical assistance or to be able to keep their house. I mean, that's just the reality of it. So our focus for our mutual mission is to meet the needs of the most vulnerable of our population and meeting the integrity workload. However, projecting how to accomplish this is getting harder and harder. as is how to equitably prioritize those workloads. So you look at managing and projecting workloads are somewhat simultaneous. So when a new DDS year starts, SSA may direct the DDSs that CDRs will be the priority workload for that year. So the DDSs put together spending plans and operational plans at the start of the year with that initial priority in mind. However, the ability to manage that priority workload is going to be only as good as the stability of your workforce for the factors we've already talked about. As a DDS may start out the fiscal year with staffing capacity to work CDRs, by the first quarter of the year, that skilled workforce is gone, yet the performance numbers remain the same. This creates a management nightmare for several reasons, but not just the national reason. In addition to the state DDSs having performance goals with SSA, we also have goals established in our states, and these goals are established with generally legislative intent, and the ability to move or modify state performance or benchmarks is not something easily accomplished, and there's a lot of explaining to do. So even though our program's 100% federally funded, DDSs are state employees, and as we've talked about, the states establish these reporting requirements at the state level that we have to speak to. And when we have little control over the workload that comes into the state, or the types of cases we're going to work, or even when a case is going to be reprioritized, maybe at CDRs in mid-year they change it to initials or recons, it makes explaining to the state how you've missed your federal performance measures a real challenge. So operating a DDS, as mentioned earlier from my peers, requires managing and reporting to two separate entities. You have a state leadership that has these expectations and requirements for you, and then you have that of SSA. You talk about losses, and when a DDS of any size experiences losses, the projections are going to have to change throughout the year. Current process to manage the federal workloads and adjust based on state-specific factors has to be considered. The impact staff turnover has on the management of those workloads cannot be understated. One of SSA's answers to meeting your targets is to provide the DDS with hiring authority or overtime. That's great, and we welcome all hiring authority. But as well, overtime and hiring authority does not always equate to a filled or even trained position in the year. First, you have to find the qualified staff to fill the position, and you have to balance workload fatigue with the amount of overtime you offer. Filling a position in August or working overtime in the last quarter of the year is not going to equate to meeting to your targeted performances. As Ian mentioned and Leon mentioned, you're talking 18 months to 2 years to train a qualified staff. You add a pandemic to the deployment of a new case process and the deployment of DCPS to the mix, and you're adding another 6 months to that training. That's if you can find the staff to even hire. As you heard, and when I talked about Austin specific and kind of where we are in Texas, the attrition, at least in Texas, is alarming. We simply can't find staff. This past year, we tried to hire 100 new examiners. We realized 17 qualified applicants. This is huge. It's a real problem, and it's one that we have to all come together and truly understand. Personnel is a responsibility of the state. We have worked with our parent agency to find solutions to help mitigate the overwhelming issues with finding and retaining staff. Our parent agencies come up with multiple solutions, all of which have been supported by state law. They're consistently applied within the state, yet for over a year now, we've been unable to get SSA to support our decisions and our plans to address these hiring inequities. Employees become frustrated, and the state questions why we're not permitted to address the inequity in pay, and it just becomes a cyclical problem for us. DDSs have some of the most dedicated and compassionate staff. We are asking them to do in the face of so many challenges is not sustainable. In our state, DDS employees were all considered essential workers by our officials during the pandemic. That didn't surprise me at all because they are unequivocally true heroes. When a DDS presents solutions to problems, though, there should be a fair and balanced and timely response to get these addressed. As my peers mentioned earlier, it just takes forever to try to get some change facilitated within this process of our system. When you look at the whole budgeting piece of it, so when it is difficult to manage a moving target, you can imagine that trying to budget it becomes an even greater challenge. It's hard to budget your workloads when you have such uncertainty of staffing and other resources. During the pandemic, as we all know, SSA suspended some of the workloads. Claimants didn't have to attend CEs. Some of the suspensions remain in place, and addressing the impact of the workload suspensions affects all DDS's ability to budget effectively. In the CE piece, if a DDS scheduled a CE and budgeted accordingly, but the claimant opted not to go, the DDS has to cancel the CE, anticipate the impact of rescheduling on both the budget and the timeline for rescheduling, and then adding the case back into the pending so that it can be worked in the workload eventually. You look at the MERS and the CEs, and you adding to the trouble of effective workload planning has been difficult in resuming and identifying sources. Again, not all DDSs have used the same CE sources as we heard earlier. Some use large volume providers, and others have outsourced the scheduling, while others recruit and find their own sources. For Texas, all available CE providers' offices are still, to this day, not open, and some of them have just elected not to reopen at all due to the pandemic. Our staff, generally our professional relations officers, go out to try to recruit the CE providers within the community to identify local sources who are willing to work, but this has also become problematic. For CEPs, these are the doctors in the community who agree to the established fees to perform CEs for the state, but a state with a significant rural area like Texas and some others, where in Texas, one county makes up 6,200 miles, there are really significant obstacles and challenges that come into play when trying to recruit and find sources, or with even trying to get a claimant to a CEP. Adding more delays and concerns is the fact that the recently deployed DCPS system at current does not have the functionality that will allow a DDS to get a claimant to a CE via a taxi. This is huge, both in metro and rural areas, because you have to have a way and an ability to get the claimant to the appointment. Pandemic further exacerbated these challenges when our staff can't travel and recruit to monitor the providers or to recruit them. The DDS has recruited 175 CEPs during the pandemic, yet we lost 451 during that same time period. Now, we've offered suggestions and ideas to help mitigate some of the CE and MER issues. However, these have not been addressed yet to date. For example, why not expand the use of telemed for all CEs, not just certain ones? Solutions have to be innovated and based on circumstances. In a time of crisis like we've all experienced, innovative ideas and concepts need to be put on the fast track. They shouldn't be put to the side saying they're being studied, which takes for years, or assigned in an area where it remains, quote, being studied for years. While it's not relevant to CE and MER, but similar as an example would be the same for hearings. As we talked about earlier, allowing video hearings would certainly provide more efficient customer service to our constituents. Certainly it has to be by choice, but our claimants, at least here, have inquired about the possibility. And it really makes no sense that an SSA Office of Hearings can do video hearings, but a state DDS can't. But, if a claimant declines to attend a telephone hearing, the DDS has to postpone the action until a face-to-face option is available. If we could do these via video, it would resolve the situation and get the workloads back to a manageable level. Again, it just increases the pending workloads. And, the impact of the pandemic we keep talking about, but it's not over. And from the most recent workload information just sent to the DDSs, it just appears that there may be an expectation in SSA to resume workloads at a pre-COVID number. Not only is this impossible, it's discouraging. DDSs were the last consideration when SSA allowed remote work with the pandemic, and that issue to date is still kind of uncertain. We don't know whether or not SSA's long-range plans are going to allow DDSs to continue work remotely. We've asked repeatedly when field offices will reopen to the public and what SSA's plans are for allowing the DDSs to continue using their equipment in a remote environment. But to date, again, nothing. And as Ian mentioned, it was a challenge when COVID hit. There were several DDSs, including Texas, who didn't have laptops yet at that point in time. So for us to even consider remote work, we had to allow staff to return to the office, dismantle their desktops, all of their towers, acknowledge that they would follow all these rules and requirements, which also included they could not use home Wi-Fi, but rather If they didn't already have it in their homes, they had to install at their expense hardwire internet services. All these conditions became challenges each DDS had to address state specifically. Even with this, there are and remain workloads that can't be processed remotely. DDSs cannot perform 100% of their job remotely. Staff have to be able to be in the office to finalize certain business processes. At a larger DDS like ours, the more staff you have, the larger you are, the more staff you have to have here. For example, no examiner can print letters or work from home, so someone has to be available on site to manage that print work. They have to get the information mailed out to the claimants to keep the workflow process going. And as Ian mentioned, SSA offered cell phones to try to help address the ability to work remotely and communicate with the constituents, but those cell phones didn't work and they didn't meet the intended need. You know, some of the examples were when a DDS calls a claimant, when the DE would call the claimant wouldn't answer the call because the call was showing up as a spam call. So they didn't know who was calling, so they wouldn't take the call. We're also hearing from our friends in our local field offices who are being inundated with mail and inquiries for claimants, but they too have limited resources to address the volume of overall work, which of course includes the disability workload. We receive claims from claimants who have no medical to support the claim, yet when we make contact with the claimant, they say the medical was left in a drop box or sent to the field office. Again, this is not the fault of the field office. Their resource capacity is just like the DDS's. It's overwhelmed. To add to that, the whole systems impact of this. During COVID and all that involved, SSA issued a mandate that all DDS's would be off their legacy system by the end of September 21 and immediately began deploying DCPS. Whether you still had a legacy contract or not, this was the mandate. It was given irrespective of any conversations with the DDS's or considerations to the issues, impact, and obstacles any state might be facing. It's hard to say what the true impact to production and performance will be because of DCPS since the pandemic is so relevant. However, with certainty, I can say, pandemic or not, our DDS would not be able to meet SSA's expected goals due to the current lack of functionality and the overwhelming workarounds that are required to use DCPS at this time. DCPS does not have the needed functionality to process claims in the manner and the integrity we're required to work. Directing the DDSs to deploy DCPS, knowing the hardships already in place due to the pandemic and the other state-specific obstacles mentioned, created even more frustration and fragility with the relationship. In our state alone, we've provided SSA with a list of 17 issues that directly impact or impede our ability to successfully process claims end-to-end, or that create workarounds that impose significant delays to working the claim. The requested functionality is not something we'd like to have, rather it's needed to meet state-specific compliance. We ask for specific dates or when we can expect the deliverables, responses are met with resistance and delay. Generally, the response will be via a phone call, and only when pushed will something come back to us in writing. And generally, what comes back in writing is a very canned and scripted response that starts something like, as you know, there are only a narrow number of claims that cannot be processed in DCPS, and the Social Security Administration uses an agile process in which to implement DCPS, etc. So it remains unclear to us who's defining the narrow and who's defining agile. But the reality is, not having this functionality or being forced to develop an individual workaround by state is counterproductive to waiting and delivering a fully functional system. SSA is probably going to suggest that the DDSs just want customization or they want their individual independence of the legacy systems. This is not true. What DDSs want is a case processing system that allows them to process claims in an efficient and timely manner the way they could pre-DCPS. It doesn't matter what kind of system we use. I'm all in favor, as Leon said, most of us are all in favor of a single system, but that system has to work. SSA is expecting each DDS, no matter the size or location, centralized or decentralized, to be alike, and that system to be alike. As you've heard from the uniquenesses we've all talked about today, it just doesn't work that way. It's just not practical. And if we're not careful, and if DCPS, not via workarounds, but the system itself, does not soon address the unique business needs of each state, the disability program will come to a standstill. When you talk about workload sharing, if a DDS is unable to timely work a claim assigned to their state, or if a federal disability processing unit or extended service team is looking for work, a DDS can, at their discretion, send work or request workload assistance. If a DDS agrees to share workloads, the cases they're transferring are going to be transferred out of DCPS, but not necessarily to be worked in DCPS. Yet one of the chief selling points of DCPS has been workload sharing. The idea that if one state lacks production capacity, another SSA component could access the workload and provide necessary support. Unfortunately, DCPS at present does not have that functionality needed to seamlessly transfer or share work in the federal components. Frankly, the federal components aren't even using DCPS, so this has placed a huge burden once again back on the DDSs. DDSs are required now because of DCPS to use associated user functionality. It is considerably more complicated and time-consuming to use than previous alternatives to transfer work. Pre-DCPS, we could find folks who needed assistance, or we could seek assistance, and it was a matter of an assistance request, and you could get the job done in literally a matter of moments. The process has become so labor-intensive and dragging down this process, folks don't even want to transfer work. The existing DCPS process is delaying our ability to process claims efficiently. Each site providing assistance has their own set of requirements in order to make the process work on their end. On the federal side, DPUs, like I said, are not required or have been directed to use DCPS, so they lack the level of understanding and familiarity with DCPS necessary to correct issues that may come up on the workload, which requires then the state to troubleshoot on any issues that arise, which only adds more time and work, again, for the state DDS. It's also important to understand in workload sharing that a state DDS may have employee capacity to assign and work the claim, and the state DDS does not want to transfer the claim, but due to the lack of functionality in DCPS, the state has no choice but to send the claim to a federal unit. Thus, the state's being required to abdicate their responsibility to work the claim and transfer it to a federal processing unit. It's not held to the same performance standards or outcomes. They're not required to use DCPS. I know I've shared a lot of information, and I tried to cover the topics you asked us to address. Today, for me, was an opportunity to begin a conversation, and perhaps will be the impetus that can initiate the rebuilding and strengthening of the state-federal partnership, one that is of great value. As I said from the start of my comments, there are good, dedicated public servants on both sides. Some of these folks, in my 43 years, have been great friends. I have looked to them as mentors. I've looked to them as folks that I count on and trust. The information that I've talked about today and my peers have talked about today should not be of any surprise to anyone, as the DDSs have been expressing these same concerns and sharing alternatives to enhance the program and relationship for years. Who really knows why the relationships have changed, but I'm a firm believer in collaboration and communication. And also, I believe that when you identify an issue, you should be ready to offer solutions. So it's my hope that after hearing from my peers today, that maybe the advisory board could consider recommendations that could bring everyone together in a spirit of real partnership. I'm willing, and I'm sure my peers are as well, to come together and establish a mutually beneficial agenda, being open to respectful conversations that truly consider the issues, impacts, and outcomes in a very positive way. With that, I will turn it back over to you.
Mary, it's Kim.
Hey, Kim.
First I wanted to thank you so much for your very articulate and comprehensive presentation. I find myself somewhat depressed, but that's okay. A couple of follow-up questions. One is you've been around a long time, and I'm curious, and this is for you and any of your colleagues can weigh in, but I'm trying to understand kind of what's happening within SSA. I know the DDSs work primarily with the DPAs, Ultimately, the DPAs report through to the regional commissioners who report through to operations. And I'm just trying to get a sense, is it your view or have things changed relative to these components having your back and really putting your issues before the leadership within the agency?
So since you asked me, I'll start, and I'm sure others can chime in. The fact is, I don't know. I think, and some of my peers have recommended this and have talked about this on national calls. I think the disability programs, certainly the DDSs, get lost in the mix. And I think, as it was talked about earlier, SSA has very specific business units. Everybody kind of has a role and a responsibility. You have quality, you have policy, you have all these very specific subject matter experts. The DDS has to be the subject matter expert to everything. And yet there's no one really in charge that we can go to get an answer. Everybody seems to have rank has its privilege, if you will. And there's, if you're at the same level as one person, you can't overstep their boundaries, so you've got to go to their boss. And then that person has to go to that boss to get an answer. I honestly believe, Kim, this is why we don't have some of the answers we've been waiting on for years. Like Leon said, for VoIP. I think there's just so much of it. It's a cyclical thing. And, you have to wonder why there's not one person in charge that the DDSs can go to and say, this is what I need. It's like my example about this thing that's been pending for us with a personnel issue or personnel. It really shouldn't be the SSA. This is a personnel that the state wants to take care of, yet we go to our partners, we ask them, here's what we want to do. Why should it take over a year to get a decision?
And assuming
it has to have you have to have a one person in charge that that's the person that can go to. As Leon said when he first came on board, when we were talking and I was talking to him, I love being a state DDS administrator because I can facilitate change and make decisions in my DDS. Easy to do.
And has the I guess another related question is, do DDSs speak with one voice? I know they're all very different. I know we have the National Council of Disability Determination Directors, but not all DDSs are members of NCDD. So
that's very true. Yeah. And I don't think we all speak with the same voice because as we're all so unique. And so, and I think that in fairness, like for DCPS, because I served on the steering committee, one of the charter members of the steering committee for DCPS, DCPS has a lot of validity and it has a lot of good. And if you're a smaller state that didn't have a lot of bandwidth, if you will, in your system, you probably love DCPS. But if you're a large centralized state with all these uniquenesses that come about and the challenges you have, it's not going to be a one size fits all. And I think that's what others spoke to earlier.
It strikes me that, and again, we're just talking here, but with all these people engaging, but if I guess to me, a key question is are there ways for the DDSs to collaborate to at least start with, I know you've had ongoing lists, so to speak, with the administration. I think, being aware of that is something that's certainly important. And I guess the other question that I would have is, do you think there is any benefit to trying to engage your parent agency heads, and I know they're different departments, or your governors on your behalf? Is this something that's been discussed? Not in a negative way, but in a collaborative kind of way, so that SSA can sit up and perhaps pay a little bit more attention in terms of the impact they're having?
So I can't speak to everybody, but I will say, at least in Texas, I mean, my governor and Health and Human Services, they look to the administrator, the commissioner of the DDS to run the program. They expect me to communicate with SSA, to coordinate with them and to facilitate change when necessary. That's what I was appointed for. Now, maybe in some states that's different, but I think we're at a loss of really who can facilitate the needed change, right? Who can make these changes happen?
So this is Ian in Pennsylvania. To your question, I too had a very difficult transition, and the state has had a very difficult transition to DCPS. And, we've started the conversation with our regional office late last year about the challenges we were facing. It escalated this past June where we were told in no uncertain terms that we had to convert over to DCPS on July 1st, which is when our maintenance contract expired on the state fiscal year. And, I engaged both my state parent agency and the governor's office, both of which were supportive. Our parent agency got on the phone with the regional commissioner's office and others from SSA and told them, hey, look, when we cut over to DCPS, we couldn't process MER. It took us about 30 days to get that functionality. We still can't process CE in DCPS, and albeit we're close to that now, but we're going on almost 3 months. And we were told in no uncertain terms we had to go. And, and that was at the highest levels of my organization. And the state went so far as to fund using state dollars, a $500,000 contract to cover our maintenance expenses for our legacy system, because our internal IT resources said the risk was so great, because at the time of cutover, we had 44 or 45,000 claims in our legacy system. And to lose that contract with that volume of work would be very dangerous. And so the state ponied up the money. I really don't know what else at least in Pennsylvania, what we could have done in those instances.
I hear you. And Ian, particularly you've had a lot of different experiences in other state agencies. Are there any lessons learned for you that you see that could even apply to the SSA DDS relationship? Where they could look, where they might look to of other programs where Fed-state partnerships do it better, and what are the keys to those successes?
That's a hard question to answer, but I think certainly, I think the first thing that we can do is just open up the conversation and have some honest and real dialogue, understanding that most likely both sides are frustrated. I can tell you my experience in state government prior to joining the DDS here in Pennsylvania, was with a state agency that administered elections. We had federal requirements there, obviously. We also licensed individuals, so there were federal requirements for appraisers and things like that. I've never personally experienced a relationship quite like this. And I just, my frustration has been, that I've approached a situation where, I'm not trying to be difficult or throw a wrench in the wheel. It's just that, we need support. And like I mentioned with our the pandemic, I can't. If I had direct control over everything, absolutely, I could make it all work. But we are autonomous as DDSs, but we don't have autonomy in certain areas, especially with IT systems. And so you're kind of helpless if you approach a situation and say, hey, look, we really need these things. And either those complaints fall on deaf ears or what have you, if that conversation doesn't engage. So I think it really comes back to, leveraging Leon and as president and some of the other DDSs to start that conversation, because our colleagues are all saying the same thing. And it's just, we've got to start somewhere. And none of us are being difficult. As my colleagues have mentioned time and time again, we don't have a problem with the system, the concept of a system. I have an IT background. A uniform system makes a lot of sense. It's just the way that this has all been done, I think, is the big problem.
It's Leon.
Thank you.
I'll jump in. Hey, a couple of things. I go back to are we all on the same page as DDS administrators and DDSs? we are different, as Mary noted, and so we're not all exactly the same, but we're consistent usually. The overwhelming majority of our administrators are part of or members of NCCCC. So we only have a handful that's not. And so again, we're on the same page. We're kind of working towards the same goal. The messaging is the same a lot of times. It's very consistent. What I'll say is that in terms of how we get things done, Mary nailed it. And Arthur Boudier, the Arkansas director, said it to us a few weeks back. So we need a decision maker. And that's the true challenge. It's not all the other things, because SSA does put in a lot of internal controls that makes life easier for us in a lot of ways. We go through state audits and things are just like already, because of our existing internal controls, we're in a really good place for a lot of things. But it's just when it comes to those really critical needs where we need a decision. It's something that's maybe uncomfortable. For example, the voice over IP. I can guarantee you it's not taking 12 years because they can't do it. It's because when you talk to the Associate Commissioner of Telecommunications and you tell them you're bringing on 20,000 users potentially, it's not something that they look forward to. And so again, but we don't have a decision maker to tell that person or those persons, well, this is the route we need to go. And this is a big part of our business. So that's where we are. Those are the things that we need. We need that decision maker. And we're lacking that. And then one of the things, kind of back to the question about the role of the regional offices and do they have our backs? I'd say yes, they traditionally have our backs. But those roles turn over and the DPAs turn over and the leadership turns over. And I can use our Philly region as an example. Our center director retired a couple of years ago, a long-term center director who was one of the more well-respected, and we were able to get things done. And then the transition to a less experienced group, now it's, things happen a lot slower, where he could make sure things would sometimes happen tomorrow. Things don't happen tomorrow anymore. Again, not that they don't have our back, it's just the experience level varies. And we need a model that where it shouldn't be totally dependent upon an individuals. So we need the decision maker.
Leon, if I can jump in really quickly, this is Jen, just letting everyone know, for the board members, Mary Wolf has a hard stop at 3:15. So we want to give you an opportunity to ask Mary any specific questions for her before she has to jump off. The other DDS directors, and this is a message for the public as well, the other DDS directors have been kind enough to, I think a couple of them at least will stay on past the 3:15 stop. So we can continue with Jackie Russell's presentation after any questions from the board for Mary Wolf. Board members, any other questions for Mary?
Hi, this is Bob. I have one question. First of all, I share the Kim's sense of depression hearing all of these problems. But early on, you talked about difficulties in hiring. I'm interested in your opinion as to why there are those difficulties.
Well, I think for, at least in Texas, the reason is we are in Austin, which has now become like the Silicon Valley. It is a huge magnet for technology. And the median starting salary of a position in Austin, the last time I looked, was $60-something thousand, median income. Median starting salary. So I think we're competing in Austin with a lot of high tech, and we just can't compete at the salaries we pay. That coupled with the fact, as I think you heard from my peers, a disability examiner job is so hard. They have to be, as you heard, an attorney, a medical expert, but then I would also add they have to know caseload management. They have to know time management and caseload management skills. You just, for $38,000 a year, when you could go to work at McDonald's and get really close to that. And I meant to pull before the call today, and I actually forgot. I would venture to say that we have 15 to 20% of our staff who have second jobs, who work this job and also carry on second jobs. because they're just trying to make ends meet. I think that's the bottom line.
Who has the
I have
power to
personally
change?
gone out and recruited myself to University of Texas at Austin and to St. Edward's to try to recruit out of the rehabilitation programs, the VR programs, because I used to work in that program. We've talked to the Texas Medical Association looking for sources that we could find potential candidates for these classes, but we have not been successful.
And in terms of the level of compensation, who has the power to change that? You've talked about having somebody who has power to do things.
Well, the state of Texas sets the classification schedules for their employees. So we set that in the state. And the state allows various things, as does the federal government, right? So you have cost of living potential, you have equity adjustments that you can give. We do not independently at the DDS make salary adjustments. And for example, the proposal that I sent out to SSA to equitize the staff at the DDS was considered by the parent agency, and it was in line with legislative direction, legislative goals that have been set, and it was not inconsistent with what other state agencies do here in Texas. So I can't answer why, because I don't have an answer back yet from SSA.
Thank you.
Sure.
Just on that, just to clarify, I think what you're saying is that parent agency in the state went along with your proposal, but you're not receiving a response from SSA. Is that the right understanding?
That is correct.
Okay, thank you.
Any other board member questions directed to Mary Wolf from Texas? Okay. Thank you, Mary. We appreciate you being on today. Leon, I hand it back to you.
And I'll just kind of echo a lot of what Mary said. I think that, you know, the job's too complex. I've shared that directly with the board before in a face-to-face session. I don't know how you make it less complex, but we've dealt with pay in Virginia in a lot of places, and it helps, and it's something that we need to do, but it's too complex. I did that job before, and I'll tell you that currently in my current role, I have a lot more responsibility, but that disability examiner job was a lot tougher. So again, it's just a complex job. It's too tough to be an entry-level state government job. And so we've got to figure out how it's simplified. So, and then I'll chime in one more thing on DCPS. To me, it's the way to go, but we need to be more strategic with it. And I think that's what's lacking, a strategic rollout and implementation plan. Again, I think we had an arbitrary deadline to be on DCPS or be out of legacy systems. And I think once you start to see that deadline's not realistic, then you change it. And that's something back to the DDS administrators. When I make a decision, I don't make all great decisions, you know, in my day-to-day work, but once I realize that one of my decisions or an initiative is bad, I just stop and I gather and regroup, and when we do something different, we don't continue down that path. And so I just think that you know, we're not being strategic enough with the rollout of DCPS. My 2 cents. No, Mary has to go, and I do want to pass to Jackie, so they don't go too much beyond our time. So Jackie.
Thank you, Leon, and thank you again for this opportunity to connect with the board and the public. I'd like to start with echoing the statements about the positive working relationship with SSA overall. I have been pleased and do feel supported by the disability program administrators in the Atlanta region. They have been very strong supporters for requests and questions that are within their control or within the region's control. And I found that to be very helpful. I want to also say, I'm going to start off by saying, if you only remember one need from DDSs, from what I share in my time, I'd like you to remember this, and that is that we have to have continued funding in place for the robust DCPS enhancements. SSA has to have continued funding in place for those enhancements, a commitment for strong funding for that enhancement work for at least 3 years. A concern I have is that in transitioning into DCPS and working to identify a enhancement process, that this energy that is around DCPS development will fade across the next year to 3 years, and that will really put the DDSs into a negative space for our claimants. And that's where we're all committed, is serving our claimants in our state. That's really important. I'm going to start off with regard to performance management by talking about some things that are, and I'm going to speak about performance management in context with DCPS. I'm going to start by talking about what's going well with DCPS. You know, I had shared that I received feedback, and I really work to listen and elicit feedback from multiple sources. And I do hear regular comments about DCPS being user-friendly, and I've experienced that myself. It's a tool that can be very effective when used correctly. The CE approval and tracking, that's a great tool for analysts and supervisors, and it makes this CE approval process easier and quicker. It has allowed staff to, I want to go back to SSA. SSA has allowed staff to work from home in these emergency conditions with the pandemic, and that has been life-saving, I'm sure, to have our over 600 people largely in their homes teleworking. That has allowed that distancing to be in place, and we've been very thankful for that. The DDSs have prioritized needs around performance, security, and quality while implementing these emergency teleworking processes, and we appreciate SSA's support of our staff and the customer service to claimants in supporting that continued telework. That's been a strong retention tool for DDSs. SSA does now have an interim process for DDSs to have input for enhancement requests. They're working on that development, and so it's a growing process. And the process for DDSs to provide input on enhancements and having those enhancements be included in the roadmap, I think it's been challenging for both parties. From SSA's perspective, I recognize they're building a national case processing system, and they have a priority on assuring there are no exclusions, as well as a priority on as strong a product and program as they can provide in the time frame that they've been given. So I understand that natural tension, and of course from DDSs, we're looking for something comparable to what we've been using. And I understand it may not be possible to provide that in a 6-month time frame. Now, as Leon shared, that's an arbitrary time frame that was set by SSA. But that just leads back to the importance of a strong enhancement process where users can give input into that process. And, you know, I'm cautiously optimistic that SSA has that moving forward. They have, you know, signaled and communicated an updated process with a person who will be leading that work in the future that will be more interactive and user driven to give input into the enhancements that are needed. So we're looking forward to that. In the supervisor's perspective, the unit overview is a fast and easy way to quickly gauge how their analysts are doing. We look closely at our support components, so professional relations. Their fiscal screens mimic the legacy screens for the most part, and those are easy to navigate. So that's a positive. We like the ability to use the filters quickly to locate certain cases or sorting MER. And the access to particular records is faster. Requesting MER and CEs, our supervisors find that to be faster and requiring less clicks And that's really what it's all about. How many clicks to get to what you need. Our supervisors can pull up a team member's caseload, and within a couple clicks, they can see how many cases were closed today or last week or last month, which gives a better perspective of that overall performance. And performance management, as you know, is very critical because we all take our work so serious. Now, moving to some areas of need with DCPS and performance management, I'm not going to give you a list of the enhancements we'd like to see. I'm just going to give you some summaries of the challenges that we're dealing with so that you can have some additional perspective on that. One in particular is when an analyst is reviewing the CE and MER, we are waiting on an enhancement to be complete so that it shows in their summary page that if they have read a CE or MER, it shows that across any summary page, that they don't have to go in individually and click it to clear after they've read it once. That's cumbersome and time consuming for analysts. From a professional relations office standpoint, their dashboard, most of their work in DCPS is an amalgamation of using several dashboards combined, the CE scheduler, fiscal, and analyst dashboards. And they're unable to create a central referrals queue, which subsequently they have to forward referrals from that queue to the appropriate professional relations team. And so it's very cumbersome and very time consuming. There are a lot of categories that are needed. And again, I echo the benefit around one case processing system, but we do have to look through and see what are the highest yield enhancements that are needed for our analysts and our supervisors for performance management. At this time, we're not able to see what's receipted in each week within a unit overall and the overall closures. Of course, there are some areas that are impacting quality, and that would be that currently analysts can move forward a case to closure on their own. Now, there are some workarounds. As Mary said, we have workarounds on top of workarounds. So there are workarounds you can put in place to have that not happen, but it causes extra tasks to then be taken later in the case adjudication process. And so it's a lot of challenges with that. Speaking about quality and talking about what can SSA do to help morale, I think it's very important to continue messaging and to maybe dig a little deeper into the messaging that when you turn over the apple cart and you go into a completely new case processing system, it only makes sense that there are going to be some quality challenges in that transition process. But I don't know that I have really heard SSA speak too much about that at the DDS administrator meetings. And I think having some messaging going out directly to the analysts from SSA would be very helpful because our analysts are working very hard and they take this work very serious, as well as their supervisors. And so they, have a lot of struggle around those differences in quality because the manner in which they process the cases is different. We know that change theory, helps us understand the impact of quality and performance when you have a big change like this. This is, I hope, once in a lifetime change in terms of moving to a brand new case processing system nationally. And we've had a lot of retirements around this as well. Now, factors affecting quality review in DCPS. Again, I'm not going to run through a laundry list for you, but I do want to share that we have found it's often difficult to read the case notes in DCPS and understand what date and action actually took place. And this can be true, especially when analysts combine multiple actions into a single note. It's difficult for the quality reviewers and our internal QA as well as DQB to follow the case development path when they're trying to match up the case note actions with the actual actions taken because they're in two different places. There are a lot of challenges with regard to concurrent claims. So one factor that needs to be resolved within DCPS is We have several requests each week from various DQBs indicating they received only one title of a concurrent claim. And DCPS requires that the disability analyst must manually close each claim. Now, in our legacy system, that required only one closure action to close both claims. In DDS, the quality assurance analyst must contact the disability analyst and ask them to properly clear the other claim, and then advise the respective DQB that they can proceed with that review. And so there are just many cumbersome aspects to that. I would also say that vocational issues are hurting us tremendously when it comes to quality. We have had a lot of work around, of course, the work histories and job classifications. And each of those on average takes an hour, some an hour and a half. Occasionally, some are more around 30 minutes, but in every case, it's a significant amount of time. And one thing that slows us down is that the 3369 is not connected directly to DCPS. We have to go out into eView and click through many different screens and adjustments before we finally get to the uniforms and the 3369. So that process alone takes 5 to 10 minutes every time you have to go back in and try to get to it. So, it's a cumbersome process. Speaking to some additional factors affecting performance in production, I want to make sure to speak to the decision to not allow phone hearings at this time. Mary spoke to video hearings. Our state has had the opportunity to pilot video hearings, and we find many claimants reject the opportunity to engage in video hearings. We're glad to have the opportunity to offer it. But we have a large backlog of disability hearings as claimants are allowed to refuse a hearing if it's not in person. Now, the policy 33025.085 clearly allows this, that a disability hearing officer can conduct a hearing by phone when extraordinary circumstances prevent the beneficiary or recipient from appearing at the hearing in person. And the example given in extraordinary circumstances includes natural disasters. And under those circumstances, the beneficiary or recipient doesn't have an opportunity to object to appearing by telephone. So we have some policy that allows those hearings. We're going on more than a year now where these hearings are backlogged, and that's definitely a challenge for all parties. I want to also speak to the ability to edit correspondence and use attachments. With DCPS, none of that can occur at a state level. And opening tickets with DCPS to edit our letters can take months and upwards of a year to be resolved. If we had state control for correspondence, edits could be done within minutes. And we'd be able to utilize attachments for correspondence to follow North Carolina specific business processes and tailor our communications to claimants and vendors specific to our needs. And that increases customer service. An example of this is DCPS doesn't print maps for CE appointments for claimants to know where to go to because we cannot include attachments. I want to be sensitive to time because I know we're past time. So I'm going to move on to the technology needs as an aspect. We've spoken about VoIP, and I want to tag in a little bit to what Jagadish mentioned when he wondered why and how successes have happened. And I want to share that I believe it's when we have commitment to a common goal that we see these successes happen. With the transition to this emergency teleworking in March, we received support from ODD to move our staff to telework. And North Carolina was able to move 400 of our 600 staff to telework within 5 days. And that's because we had the approval from SSA to move that forward and the latitude to have a process that aligned with SSA's parameters and aligned with our business needs. And that's the level of autonomy we need to be able to operate at. And with situations or with needs such as VoIP, we need to have SSA come to the table and identify what we can have access to, instead of this lengthy time frame of trying to schedule us into the SSA agency process for VoIP. Many states have the ability to engage in VoIP with, as Ian shared, with their state VoIP system. And I believe if we could have a commitment from SSA to help us identify where we can find common ground on the parameters, that we'd be able to find a way to navigate that. And in 2 years or 3 years or 4 years, when SSA is ready to provide that to DDSs, we can switch over to the national system. But it's critical for us to have this access to this technology. Some additional aspects to share with you about the current flip phones that we're using is that, as Mary shared, they do not reflect the DDS as the caller on caller ID, so our claimants don't answer our calls. And the voicemail capacity is very limited, as they were not designed for high volume business. Now, I will say, I think of it a little bit like, I like to install special little light switch plates in my house. I like to have them for where I travel or something that I see that brings me joy. So when I do that, I need a screwdriver, right? So I take off the other switch plate and I use my screwdriver to screw the new one in. Now, if Leon gave me a toothpick to use instead of the screwdriver, I would appreciate the sentiment and I would try to do the best I could with that toothpick, but it's not the tool for the job. And we need the tool for the job. And it's not just related to a different type of phone system. The VoIP system provides a call center and other forms of triage functionality as the first point of service delivery. It supports addressing performance issues and training needs for our analysts. And these non-VoIP systems in the current flip cell phones don't provide those same customer service benefits. And I believe SSA has good intention. And, I've heard a few people say they feel a bit discouraged. I have to tell you, I don't feel discouraged. I see a partner in SSA. And quite often when I ask a question, I don't get the answer that I want, but I just keep asking more questions to try to figure out how we can find common ground. And I feel that that's what we need to do. I appreciate SSA's, this advisory board, in helping us to do that. I'll pause it there, and I want to just make sure we have time for the other aspects that Jen has identified.
Thanks, Jackie. I think you made some really good points. I love the toothpick screwdriver analogy. That's good. But we are in a place where I think we have a partner, but it's just one of those things where we're trying to figure out how best to get things done. And in SSA, a lot of times, it's a massive bureaucracy, and it's hard to get things done in a timely fashion. And from a DDS perspective, from outside looking in, we have things that we have to accomplish, whether it be personnel things that our legacy system or DCPS needs to take care of. And those things are urgent for us. And it's key to our business process and how we evaluate people and things that we've, told our parent agency that we're going to do, or we've committed to. And those things, we have to have some voice at the table in terms of prioritizing where that all goes. And I think that's it's one of our bigger concerns with just DCPS in general. And then I'll talk a little about the performance and quality. A little different take than where Jackie was, but kind of back to what Art and Melissa talked about this morning. The DDS does a good job with quality. And quality, it's all about how you define it. And we've had numerous and years worth of discussions. We index spent years on quality at the DDS level. And it truly is how you define quality. And so what's a return? Is returning a claim from QA that's going to delay the case 2 more weeks for something that has no impact on the decisional accuracy. is that a good decision? It only negatively impacts the service to the customer. So those types of things, and it's where we all need to be at the table and kind of decide on. We were in an index session once, and we were talking about how SSA's federal units does quality reviews, conducts quality reviews versus the DDSs. And we all figure it's still pretty similar. So when we see these swings and in quality at the DDS level, it's usually something, and DDSs will tell you that we don't turn our quality, doesn't turn on a dime. So if there's a huge change in the DDS quality, it's usually not about the DDS. It's where the SSA hired a lot of inexperienced reviewers in one of their offices or multiple of their offices. It's where something was going on, or they had a conversation about how to look at cases differently. And those things are things that I think, back to the communication, if DDSs know, I think those things should be shared, whether it's new staff on that may make a change, whether there's emphasis in a certain area. And those are the things I think, if DDSs have the exact same training, same communication that we're communicating to federal quality units, I don't think you see those big changes and swings in quality. And eventually we're all kind of looking at the quality, the approach to quality the same way. And so it shouldn't be an I got you thing. So again, kind of like not sharing, an emphasis in a certain area with the DDSs. This gives the federal units an opportunity to return more cases and find more I got yous. Where if you share that at the same time, the end goal is service to the customer. We all learn and we're in the same place. So I think those are the types of things that, from a quality perspective and some of the metrics and performance perspectives, we need to be thinking about and talking about more. And I won't go into processing time and workloads. We talked a lot about that earlier today. But that's for the board. Anyone, public, even any more questions for Jackie, Ian, or I? Ian, anything else to add before we go there?
No, thank you, Leon.
All right, so I'm going to open it for questions for any of us. And it doesn't have to be just on Jackie's session. It could be on anything we discussed today.
So I'd like to ask about something you mentioned earlier, which is the job is just too complicated and it involves lawyers and the physician's job without those degrees and so on. I mean, adjudicating disability has been the job for many, many years and decades. And I don't think, I understand that some of the listings and so on have been revised, and there is new material, types of cases change and so on. But it hasn't changed so drastically that it has qualitatively become more, has made a quantum leap in the degree of complication over the years. And you should correct me if I'm misinformed about this. So should I take your comment that it's a complicated job to be a relative comment, meaning that it's more complicated than the compensation that is offered for doing it? Or is it just complicated and it's just humanly very difficult to get your head around doing it properly, despite the training and so on? I just want to understand that comment a little better.
Ian and Jack, you can feel free to jump in as well. But what I'll share is that it's more complicated in a lot of ways in terms of like the macro level and sequential evaluation. I get it, that hadn't changed. How you go about processing case and thinking through it hadn't changed, but the little processes have changed. And so there's things, whether it be how we approach it with DCPS versus using the legacy systems, whether we are looking at work history and vocational development, those types of things, while it's on a surface level, it's been the same forever, it's gotten a lot more complex in terms of how you deal with some of the vocational things, what we have to document, what the examiner has to call and clarify and asking the claimant in terms about detailed work history. Honestly, we get a lot of returns about this clarification of work histories. Most of our customers, can't even answer the questions that that we were expected to answer about their work history. They don't have that information. Some of them just don't even recall, much less have it. So those are things that we're spending a lot of time on in terms of just the failure to cooperate policy, for example. That's just to be honest with you, I still don't understand it myself. And again, it's changed so many times. And I can't expect the examiners to nail that. And it's just it's those types of things that are doesn't seem big, but when you add all those little things together, it is really big, and it's a difficult job to remember all of those little things and stay on top of those things. And those things change so often and require such like minutia in terms of the detail. And then it's back to the QA example. If I've done all those things and and I close the claim and it gets pulled for federal QA review, and then it's returned to me because I didn't follow up on a podiatrist visit for the claimant when they're alleging back problems. So again, all of a sudden the case has been delayed. I have to follow just one follow up to a source that's going to add no value. It's totally irrelevant, and so it's those types of things. So the process is complex, challenging. Again, we're trying to use two different systems right now, and that's complex. That should go away at some point. But examiners have routines. They have tools. We have internal controls built into one system to help them be good at the job they've done. They've been doing for years, and all of a sudden you transition to this other tool, and you don't have the same internal controls within that system to do so. Some of them are figuring out how to do their jobs all over again because of the lack of those internal controls. And I'll use one of the quality examples again. We, as part of our product quality review process, we have end-of-line QA reviews, but our supervisors also and case consultants also did inline QA reviews. Today, there is no ability to do inline QA review within DCPS. So that's a whole part of our quality process that's kind of like on delay or not available until DCPS can build some of that functionality in. And so again, like 6 months from now, if there are quality problems, I can't say that we've changed a lot about what we're doing, but we've eliminated a whole layer of what we were doing in terms of QA review at the DDS level. So those things I expect to see some impact. But again, overall, the job is still it's difficult. DCPS and not it's difficult for the examiners, and it takes a lot of work. Today, one of the things has changed, and people don't think of it in a bad thing because it's really not. We have the HITMER. HITMER comes in, and somebody spoke about it earlier. Sometimes the examiner get the case, and the MER is already in the file. So if you ask Leon from 20 years ago as an examiner, I'd love to have all my MER in file on day one, I would say yes. But today, that represents a huge challenge because we are so much more efficient with getting the MER in. There are hundreds of pages of MER that's in file. So again, when Leon was an examiner starting out, you develop a claim today, you put it in the drawer, you follow up at 10 days, and then and make sure so it was all these little stops along the process so I could do it methodically. Today, things are coming in real time all the time. So 10 years ago, I would read MER, kind of check this off, okay, this case still not ready, and waiting on this thing. Now, the way it works, I may read all my MER this morning. By the afternoon, there's something else in the claim that I have to go back and touch again because I have an alert that's more MER. So again, examiner's job is just getting tougher and tougher, and it's extremely difficult to manage in this new environment. And technology is good and bad. So that's just made the job a lot more complicated.
I'd like to comment on that too. With regard to the tasks and the salary, we have states in our region that the analyst pay is lower than $30,000. And it's a very complex job. And to try to increase that salary rate, there are requirements that SSA has of a state to try to request increasing the starting salary for that position, even though the position is already approved through the state agency. at a classification and compensation rate. So the state has approved this position, analyst, at a certain rate, at a certain salary band, but SSA is requiring requests for increasing the starting salary, even if it's just within the first quartile, to go through the regional office first with quite a bit of required paperwork and to go along with that. And to me, that's nonsensical, because if you have it approved through your parent agency, a salary band that aligns with the compensation and classification requirements, and you have it in your budget, you're not asking for more money from SSA, that feels a bit like red tape. And I know that's what none of us are about. So I just wanted to add that element to the conversation. Thank you.
Thanks so much, Jackie. Thanks, Leon. Thanks, everyone. I am sensitive. We are way over time. I want to give, if it's okay, Leon, give board members one more pass, and then we'll
Sure.
wrap it up. Any board member questions?
Yeah, let me ask sort of a more general question. And that is that, and correct me if I'm wrong, but I believe I've heard that some of the DBSs have consumer committees that can provide them with community feedback and so forth. I don't know if that's correct. If it is that a helpful kind of thing to do, or is it necessary? How would you go about it? I mean, when I heard about it, it sounded like a good idea to me. So I was curious if that's correct and what you all think.
Ian, Jackie, feel free to chime in. I'm not familiar with a consumer committee per se, but our pros and directors do engage in a lot of different groups in the community. And so whether that's just going out, talking with SOAR coordinators, whether that's educating, prisons on pre-release claims and learning more about what's happening with that population, whether that's in Virginia, we actually have a partnership group with advocates. And so we have quarterly meetings with that group. So there are a lot of different ways that we try to interact with the various sectors across the relevant parts of the community, just to make sure they're being involved. Just small things, just teaching reps how to upload things to ERE or whatever. So those types of things are happening and ongoing.
Leon, this is Claire. I just had a quick question kind of to follow up on Jagadish's question about the complexity. Is the role of the courts in interpreting policy, has that added to the complexity, especially as you are starting to transfer cases potentially from one judicial district to another? Is there training for the different rulings depending on the judicial district?
Yes, the acquiescence rulings. Yes, I'm familiar with that probably more than anybody else in this group, because I have the EST and we do a lot of workload sharing. And so, yes, whenever we do work for another state, we have to look at acquiescence rulings, train our staff on that, get them up to speed. And the theory behind all workload sharing is that the work's done better in the home state. So when you're doing it in another state or another unit, we want to mimic their processes as much as we can. So when we're sharing work, we not only deal with acquiescence rulings, we pay the same MER rates that they pay in their state. Obviously, we order CEs through their state. We redo our letters so that the letters that goes out on those cases look like the letters that read like the letters that's coming from the home state, et cetera.
Leon, if I can circle back one more time, I know Ian Harlow has an advisory committee in the Commonwealth of Pennsylvania. Ian, did you have anything to add regarding Nancy's question?
Thank you. Yes. So we meet on a quarterly basis with Community Legal Services out of Philadelphia, and they pull in advocates and lawyers from across the state. We find those meetings very helpful. And then we also meet with the Philadelphia Bar Association biannually. And so a recent example of kind of a project we worked on was during the pandemic. The CLS had indicated that we were having some language access issues in the Commonwealth. And so We worked out what language we would offer certain things in. We found out what was available to us through the Social Security Administration. And basically, we included a one-page insert in all of our mailings because, folks were missing the language flag at the field office. And that's not meant to be critical of them. It just happened. And so to make sure that we were catching everyone, we added this insert that was in, I think the top 7 or 10 most spoken languages besides English in Pennsylvania. So we included that flyer. And then at the same time, we were rolling out a virtual call center here in Pennsylvania, and we added those language options to the call center. So we did that hand in hand. The advocates were very happy. It would have been an issue that we weren't really aware of, and so it's just a good example of coordination. And we're very proud of that initiative.
Great. Let me circle back, if it's all right, to our board chair. Bob, do you have any questions for the group?
I don't, but I really appreciate the fact that people have stayed with us so long. I was particularly struck by Leon's statements about how technology gives with one hand and takes with the other, in that having systems that aren't efficient in sharing information can be a problem, but at the same time, an inundation of information can overwhelm a system, overwhelm a worker. And I think these are real management challenges ahead in any environment. Certainly you have very many of those. But the last thing I just want to say is that I particularly appreciate all the work that you do. The amount of knowledge and attention to the problems that you confront has just been amazing to me. And I've learned an awful lot today, and I'm sure other participants have as well. So I really want to thank you, and hope that our board can continue to work to work with you to improve how the system works. Thanks. Nancy, you're muted. Yeah. Okay. So I think with that, Jen, are we ready to wrap it up?
I think we are, Bob. Thank you so much for those words. I will say to all of the people in the public who submitted questions that we did not get to, we're very sorry. If you put those in our events mailbox, events@ssab.gov, that's the email address. If you are willing to, if you really would like us to circle back to the DDSs with your question, we're happy to do that if you just email them to us so we can get back to you. That's all I've got, Bob. Thank you.
All righty. Thank you very much, and have a wonderful evening.
Thank you, all of you. Thank you very much. Very informative.
Take care.
Thank you.